My name is Don Elliman. I'm the Chancellor of the University of Colorado here on the Anschutz Medical Campus, and I'm here to welcome you. That's my sole job in this event today. I should acknowledge the fact that we're actually in a building that is part of UC Health, which is an independent entity of the university. So we're grateful for their support for this, for providing this facility. But we're thrilled you're here. The subjects that you're going to be talking about today are absolutely at the fore of how we are thinking about our future, not only for the 5 schools that we have on this campus, but for the mission of the university as a whole. And I'm looking forward to being a part of the audience and hearing what our various panels have to say about personalized medicine and data sharing and the other subjects that we're covering today. So once again, welcome. We're delighted to have you here. The biggest single problem on this campus is parking, so I sincerely hope you were able to find a place to bring your car. But other than that, we hope you enjoy the afternoon, and thanks for being here.
Hi there, my name is Phil Weiser, and I'm a friend of Don's and the Dean of the Law School in UC Boulder. It's special to have cross-campus collaboration and also have conversations around entrepreneurship and innovation that engages this community. We've now had 3 years in a row of a healthcare innovation conference here at the Anschutz campus. I think Anish Chopra has been here for all 3, and Bruce Johnson here at Posanelli has helped get the law firm to sponsor all 3 conferences. The interesting issues involving technological change, innovation in our healthcare system is something that I have a real interest in from many vantage points. For those lawyers in the room, and we probably have got a pretty diverse audience. How many people in the room are students, either law students or med students? All right, hopefully more keep coming. How many are lawyers? Okay, decent showing. How many would say entrepreneurs? How many doctors? How many people raise their hand for more than one category? All right, we love you guys. That's the goal here, to encourage more people to be more categories. So you doctors want to go to law school? Come talk to me. There's opportunities. Those doctors or lawyers want to be entrepreneurs? Come talk to Anish afterwards. There are so many opportunities in this space. And one of the conversations that will keep happening is how to adapt to these changes, both from a healthcare practice, from a law and policy point of view, because technological change and entrepreneurship are making big impacts. We have 3 panels touching on critical issues. We've got an extraordinary lineup of speakers. I want to thank, again, Posanelli, all the sponsors, Silicon Flatirons, and thank, again, Don, the Anschutz Medical Campus. They're really great collaborators, and we're happy to be having this conference once again. So without further ado, Bruce, take it away.
Thanks, Phil. You're here. Thank you. Thanks very much. I'm Bruce Johnson. It sounds like I'm echoing. Am I? Maybe it's just in my head. I'm a shareholder with Posanelli and a healthcare lawyer here in Denver, and I'm really pleased to be part of this and moderating the panel today. We're going to be talking for the first panel on the topic of enabling structures for accountable care. Actually emergent structures for accountable care. And we're going to be talking about this concept of accountable care, which doesn't necessarily have a precise definition, but I think in my mind it is commonly referred to as kind of a multifaceted structure for the delivery, the financing, the organization, and the management of healthcare services through a variety of means. There's also, it's also commonly referred to as value-based payment systems and value-based care. But it's, in our panel today, we've got a number of presenters that are going to provide a variety of perspectives. I'm going to do very brief introductions before we get into the discussion. First is Anish Chopra, who is the former, was a first U.S. technology officer under the Obama administration. And Anish is also the founder of Hunch Analytics that engages in population health and communication and other strategies. Brent James is a physician with Intermountain Healthcare. He's the over the healthcare delivery research program with Intermountain. David Pinkert is with, is it Canopy or Melody?
Good question. Canopy.
Canopy, okay, because I read two different things. Canopy Health Insurance, which is a program designed to engage in state-run exchanges and health insurance for individuals. And then Mark Prather is the CEO, is a physician, and he's the CEO of Dispatch Health that deals with mobile on-site treatment and related programs. So we're going to be talking, as I said, about emerging structures for delivering accountable care. And I'm going to start it out maybe with Brent. Maybe you can talk a little bit about how the changing environment has affected Intermountain and some of the things that you're doing in that environment.
The truth is, Bruce, is back in the late 1980s, we began to study variation in care delivery, found massive variation at the level of individual physicians treating statistically identical patients. Fed those data back. As the variation declined, our clinical outcomes improved and our costs fell rather dramatically. Led us to W. Edwards Deming and his process management theory. He had a theory that described what we were seeing, and we pushed into that area. In the mid-90s, we launched an effort to begin to manage clinical care as a care delivery group. We call it clinical integration. We didn't really have a management structure for the clinical part of our business, which is our core, frankly. Key process analysis, data systems, a series of large registries aligned to specific clinical conditions to make the care transparent, particularly to the patients and to the physicians and nurses who execute it. An organizational structure for accountability, and finally, aligned financial incentives. In more recent years, our ability to manage care has led us to actively seek capitation at every opportunity. It has to do with payment mechanisms and who gets the money when you eliminate waste. Our estimates of waste in healthcare run as high as 70%. Of all money spent on healthcare delivery in the United States today is non-value adding from a patient's perspective. To Deming, technically waste. That's 70% of this year, a $3.2 trillion spend in the U.S. We have, to date, well, in the last 4 years, pulled out about $700 million. It's about 13% of our total cost of operations. And because we're capitated for, currently about 38% of our care, that's been a very positive financial model for us. If we hadn't been, most of the savings flow back to others, not to those who actually do the work. And so it has to do, accountable care organizations have to do with aligning financial incentives at their core. Fee-for-service payment, I think, is dead. Bundled or per case payment, we'll see increases, but the ultimate goal is full per member per month capitation for care delivery groups, I believe. At least that's a hypothesis. Okay.
So, David, you're on the insurance side, you're on the payer side. How are you looking at this world?
Remarkably similar to Brent's perspective. As we go out and develop new networks in new markets, which is we're doing quite a bit of that right now. Our philosophy is we want to, to the best of our ability, separate insurance risk from clinical risk. We're an insurance company. We should be in the business of taking insurance risk, and we want our providers to manage the risk that they have the ability to manage. Some of that comes down to financial incentives. Some of that comes down to us staying out of the way as an insurance company and not preventing them from doing the right thing or creating incentives or disincentives that conflict with good clinical care. So that's our philosophy going into it. But where the rubber meets the road is not everybody is an Intermountain health system and has the infrastructure to manage that kind of risk. And so the challenge for us is as we go into a market and meet a delivery system that says we want to go all the way to capitation, for us to actually put on the brakes sometimes and say, okay, now what population health management programs do you have in place? What infrastructure do you have in place? Will you actually be able to drive a higher quality experience if we can really get out of your way and, capitate you and let you go about your business? So when we have the opportunity to work with an Intermountain that really does have that infrastructure and can, take a greater level of risk, we love it. And, we go really fast. In other markets, we're having to at least step it back from there and share risk in a way that our provider partners actually have the ability to manage, with the idea that we're going to progress together towards something that involves a much higher level of capitation and full PMPM risk.
So what's the role of an organization like HUSH? hunch or
Well,
what's your perspective?
I'm going to wear my former CTO hat. 'Cause
Okay.
That's probably more relevant than specific startup ideas. When Phil and I were in the administration, we were part of the team that looked at how we bring basically three streams of activity together to address what may seem to others as a really hard. If you listen to David and Brett, David's going to pull the stops off, and Brett can do it, but he's got like a genius Godfather-like ability that is hard to replicate. So what does that mean for the rest of us? 95% of the providers that are not Intermountain. And we had this challenge, which is we wanted to create the right guardrails for payment reform. So every community doctor in America could conceivably be on this train. They may not be as mature as a part of an Intermountain organization, but they're going to take step 1 and then 2, 3, 4. And to do that, we needed to provide resources that would make them successful. So, one of those was we had to provide data resources. So the federal government did something very dramatic. It said, look, you are the primary care doctor. You see and you generate, the average primary care doctor in America is between 4 and 6% of the total bill. So 95% of the bill you didn't charge. But you probably had a hand in influencing what was in that 95% bucket. In other words, the percentage of things that you influence exceeds that which you bill. So the radical decision that we worked on was we're going to allow doctors who want to take that first step into population health or accountable care. We'll give you a financial bonus if you can help manage the care of the patient. And in exchange, we're going to give you data. We're going to tell you all the places that patient sought care. Now, you've got to stand up the infrastructure to understand that information because you didn't generate those bills, but you might be able to look at those bills and say, why is this doctor, basically take it from the bottom up of what Brent's describing, why is there clinical variation in how people are treating patients that are clinically similar with back pain? And so now you've got essentially a two-horse race in the American care delivery system. One horse is for organizations that are reaching Intermountain level maturity, Kaiser, others, they're going to kind of incrementally compete and improve upon the model, and you'll see many, many more markets have at least one Intermountain or Kaiser-like entity. But you'll have a flip of that, which is the Bizarro to Superman, where you've got, with no value judgments on who's good or bad, but basically you'll have other models, which is I'm a sort of a small group of doctors responsible for a panel of, call it 5,000 lives, and we're going to manage them in a way that we think we can do, but we hadn't been asked to do and weren't incentivized to do. And both are trying to reduce that unnecessary utilization, and there are rewards along the way. And they're going to have pretty radically different operating models, IT infrastructures. One will look more like the internet, one might look more like an enterprise, and we'll sort of see what will happen as they mature.
So let me ask you, Mark, why don't you talk a little bit about your dispatch health and how it fits in with this concept of capitation to some degree and some of the other details of how it works.
So I'm an ER doc by training, and actually for the last 6 or 7 years have run an outsourced ER provider group, and that group makes its money by generating volume through an ER at a fairly high rate. And a few years back, I looked at that and said, this is not sustainable. Looking at the volume that's coming through the door, 40 to 60% of that volume probably doesn't need to be there. So am I part of the problem or the solution? So I'd rather be part of the solution. So that's really what dispatch health is. What it is an ER to your door. Fairly high acuity events can be treated in a nursing home, a assisted living facility, or your home. So things that are traditionally treated in the ER, urinary retention where you have to place a catheter, replacement of a gastrostomy tube, those are actually very easy procedures, and there's no reason that they need to occur inside the four walls of the hospital. So that's really what dispatch health is about, and the delta, the savings on each of these is fairly significant. So really we fit in as just an alternative delivery model, and I think you'll see more and more of that. Somebody will look at the OR and say, hey, we can do this differently. So dispatch health is being well received in this new world.
So are there other opportunities like that? I guess, Brett, from your perspective, things that you see that whether it's a dispatch-like model or other models of care delivery and cost savings, if you will?
There are actually quite a number of them. I tend to classify them in particular ways. It's a three-part financial model that starts down at fee-for-service. It's unit of care. So what's your spend for unit of care? A dose of a drug, a single lab test. Then you move up a level to what's called intracase utilization. It's I pick 4 of that one, 2 of that one, 1 of that one, 16 of that one, build it together into a treatment or a case. Physicians and nurses control that. That's where the variation analysis really hits hard. The third level is population health. It's a case rate within a population. In quality theory, we call them move upstream strategies. So quality improvement's inherently a preventive strategy, and as you move upstream, for example, you might be able to dramatically drop hospitalization rates, which is what you're doing. Exactly. Basically, keep them out of the ED, keep them out of the hospital, because the need disappears. Of that 700 million I mentioned, about half of it was those. Now it ties to payment. If I'm paid fee for service, then it turns out the per case improvement and the population improvement, all of the savings goes back to someone else, you actually, to the insurers, the payers, and those who have to drive the change are financially punished. They have to fund the change and are financially punished. If I'm paid per case, then it makes sense to deal with intracase utilization. If I'm capitated, I get all 3. You see the idea. We call them hot-spotting strategies when you come to population health. Some have to do with behaviors, getting people to not have the need. So 40% of your health depends on your own behaviors. It's the single biggest category. About 40%. Only about 5 to 10% depends on the care delivery system. The chief stealers of human health are number 1, tobacco. Number 2, alcohol and other recreational drugs. Number 3 is obesity still. It may be moving into number 2.
Yes.
Diet and exercise. Number 4 is sexually transmitted disease, including AIDS. Number 5 is unwed pregnancy. It used to be teenage. It's honestly in the life of the neonate. It's pregnancy without a strong social support network. Number 6, violence, accidents, suicide, particularly among young men. Those 6 account for more than half of all healthcare expenditures in the world today, right there. So you can change behaviors. Very tightly linked to education levels. The other piece, we call it hot spotting, where you identify chronic high utilizers and act upon them, or you identify with predictive analytics those who are likely to be high utilizers in the future. I put together a little white paper for use inside Intermountain, 6 pages long, and I think I came up with 60 of them, just from what I'd read about or knew about that fell into those categories. There's lots of opportunity that groups could pursue.
I'd love to read that memo.
Oh, yeah, it's a pretty, I bet you could write it.
How about others? Anish, what do you see as opportunity?
I think here's the any of you guys play Frogger when you were younger? The game that you had to try to get you had to cross the highway. So I tend to have a bottom-up Frogger-like view of the healthcare delivery system, which is to say, most of the discussion in Washington and when we go to these places that are trying to make change, they have more of a top-down feel. We're going to organize the system, and the patient as passive member of it will sort of get better care without them even realizing it was changed. And by the way, there's a lot of good that comes from that sort of, and there's a heck of a lot of efficiency as organizations kind of go down that road. I take a slightly bottom-up view in the following way. In the 1990s, an MIT research team proposed to DARPA, but wasn't funded, an idea to create a guardian angel for every patient. And the idea was that if every patient had this guardian angel, and the guardian angel in today's era could sync with all of the digital assets, the health or social determinants assets that might be available, then the decision support layer for my guardian angel might help me make decisions at every step of the way. And in many ways, that's the anti-institutional model because they're not doing much anything. I'm just routing myself through the institution. So as it may turn out, with transparency, I may learn that a particular specialist at Intermountain has this variation reduction, and as a result, because of public data in the Medicare file, I can see that this particular doctor over others is the ideal person to go to with back pain. And even though Intermountain didn't convince me to join their health plan, as an open, free market, I can go to any doctor I want Medicare, my guardian angel may instruct me to end up there because it may be the best decision for me. So when you look at the opportunity set, again, enterprise down, Brent's going to have to buy a lot of stuff, not him, but his institution. As they continue to vet and improve and squeeze ever better, ever more opportunity, his procurement agenda will continue to expand and adjust. But then there's this other question. You know, if you truly optimize, if every person optimized every decision, and the healthcare delivery system was as variable as it is today, including, by the way, putting me on a plane, I'm from Virginia, fly me to Intermountain for care. If you think about it, if everybody made a decision at every step that was optimal for them, maybe we get half, 2/3 of that waste that Brent's talking about. Because somewhere in America, there's someone who's phenomenal at treating the condition that I have in a way that's least resource utilization for the outcome. And I would suggest that this model looks more like the internet with disposable replacement apps and app-enabled services. So there'll be lots of experimentation. And in this model, in general, selling to enterprises sucks. So if you're an entrepreneur and you want to fix the healthcare delivery system, the pace with which you have an idea that you want to get to market and test, and then, oh, by the way, it's going to take 9 months to go through a procurement cycle, man, that sucks. When your idea could go through this model and affect patients tomorrow, we will start to see cases where this has business model equal to or maybe comparable for entrepreneurs as this. And the number of actors playing in the field that can experiment, try the idea, it doesn't work, drop it out, keep going, will evolve. And I would argue the place that's really creating that bottom-up model is, ironically, the publicly funded programs, Medicare, Medicaid. One final comment about it, just because it's relevant in this example. If you need Meals on Wheels, or you need someone to help you install a ramp into your home, that's not in the EHR, typically. And it's not integrated, even if wherever it is, if it's in any digital form. Medicare has a proposal right now, and I hope someone in Colorado applied for it, the Accountable Health Communities model, which is completely bottom-up. It's built for screening 51% of all Medicare and Medicaid patients in your neighborhood, to screen them for all these social determinants, the stuff that he's describing is critical in that 6 bucket, and put that in a database, and integrate that database with providers who will take the higher risk patients and put them on high alert. Wow. I don't know if anyone in this room apply for that. Is there a community in Colorado that is likely to get that Accountable Health Communities grant? There's going to be 44 picked. Applications in process. So Phil, put your name on one. Get the Phil Weiser magic juice. You'll have a higher chance of winning. And the point is, I think the opportunity space will be fascinating when you go to those communities that have those prototypes or tests. That will give you great opportunity. One last comment. I'll stop there. Name the organization that had the first new payment model approved for value-based care under the Affordable Care Act. What external organization in America, from the bottom up, ran an experiment and said, I think my model is going to lower costs, improve value, and just got it approved 2 weeks ago? What's the name of the organization that's so healthcare entrepreneurial? Anybody here know? No, God, no. Yes? You were in my last session, don't cheat. It's the YMCA. Anyone here from the YMCA? The YMCA proposed a pre-diabetes DPP program, which the CDC had been certifying for years. Forgive me for the acronym of the yin-yang, but the premise being the actuary of CMS certified that program over the last 3 years has proven to have high return to the taxpayer and with high outcome. And so what does that mean? Well, a startup that's not in this room, Omada Health, that bills under that code, just justified their unicorn status. And they're going to go through the roof because now they have a billing code to do their diabetes prevention program, where before they didn't have one. So that's what the bottom up, as much as the top down, may be a way to think about business opportunities for entrepreneurs.
So David, you want to talk about your company? Is it a bottom-up company, or you were? I could tell you were like really focused in on what he was saying in terms of perhaps its applications. Comments on what he said?
You know, I think Anish said a couple of things that sparked ideas and reactions to me in positive ways, I promise.
Oh, good.
And, you know, the thing that I kind of react to the most is, you know, when people talk about accountable care, often the focus is on reimbursement itself. You know, how do we reform reimbursement to get to a better place from a quality or outcome standpoint in the healthcare system, or, gosh, help us value, right? And, you know, reimbursement itself isn't the interesting part. It's what's next. That's what's interesting, right? When we can start to fix some of the screwy things that fee-for-service medicine causes, then what is what we're looking forward to. And you talked about sending data out to primary care physicians so they can, you know, think a little bit more deeply about some of the referral patterns that might be happening within their practice. Well, if I'm a family practitioner and under fee-for-service medicine, I've got to see 30 visits a day.
Yes.
That doesn't happen. You can send me all the data that you want. There's no time for me to do that and to be that kind of so-called population health manager. However, in a capitated arrangement or an arrangement where I'm not so heavily dependent on just churning volume through my office, now we have time and bandwidth to do some of those value-added things that you're talking about, whether it's looking at referral patterns and actually acting on them, whether it's actually looking at my rate of generic substitution and thinking, is that something where I can actually help deliver greater value for my patients? But doing some of those things that involve a little less churn and a little more kind of thinking and processing and maybe even synthesizing on behalf of my patients, those are the what nows that get pretty exciting. You know, I'm aware of several situations within Intermountain, and you probably have some examples you could bring up that relate to that. But, you know, first get the incentives out of the way, get those relatively solved, and then, you know, help the providers either in your delivery system or in your insured network do something differently to help get to that better outcome.
Can I just react to your comment, David? Here's some interesting evidence. We've had 3+ years of the Medicare ACO program, this idea that I still live in fee-for-service medicine, but you give me a little bit of by the way, it's a one-sided bet. Right. I don't know how many of you get to go to Las Vegas and make a one-sided bet. Heads you win, tails nothing. But that's like not a very common, you know, that's not available to you. Well, every primary care doctor in America can basically take a one-sided bet by joining the program. It's basically everybody should join. I don't know why not everybody has, but let's leave that to the side. A couple interesting observations among the first few adopters. Number one, physician, and specifically primary care physician-led ACOs outperformed hospital-sponsored ACOs dramatically.
Makes sense.
So, well, but yeah, your point about they are living in fee-for-service, why bother? I got 30 patients a day. All of a sudden, they did. And they actually were quite successful at it. Here's the interesting point. If you looked at the places in America that were the most successful in the program, what was the size of the most successful ACO check, savings check, to a primary care doctor last year? One-sided risk. Anybody know? It's not public. It's not easy to, we can guesstimate. It's guesstimated that it's between $80,000 and $120,000 a doctor. Savings check, because they were able to reduce costs. And that's not an insignificant amount of money, by the way. So even though you're in a fee-for-service world, you're the opposite of capitated, you're still fee-for-service, but you did that first step, you joined the Medicare ACO program and you got the data and you had the incentive, you could dramatically change the way you operate. Now, here's an interesting question, David. When you look at what happens, all of a sudden, those doctors start asking, yeah, maybe I'm seeing 30 patients. Who are the 10 that I should be seeing that are not on my schedule today? Right? And maybe they'll go to Mark and say, hey, Mark, will you do a deal? I don't have cash to fund you, but you can take a share of the upside. Would you mind if I refer to you patients that you and I agree you're the right guy for? Do you mind if we put out an 800 number of our patients, and if they call up, yep, that's a flagged patient for you, would you do that?
That deal exists.
That deal exists.
And as an insurer, I love that as well, right? Because, you know, in my world, if a member or a consumer doesn't submit a claim because they're not being seen, then I don't know anything about them. right? I don't know what their medical history is. I don't know anything about their diagnoses, and it's very hard for me to connect with the physicians in my network to say, I need you to, we need you to pay attention to this person. We've identified some risk factors that might be helpful here. So we need that interaction, and it doesn't happen at the insurer level, particularly with someone who's not utilizing the system at all.
Yeah.
So, Anish, I have to respond to one of
Please.
your points.
Godfather.
I can tell you in detail.
He's a legend, by the way. You all know this, right? Literally. In our
Exactly.
field, he is the legend.
Well, maybe there are better legends.
No, it's true.
I can tell you precisely why we chose not to go Medicare ACO.
Well, you don't need to. You're already mature.
Well, we already had a mature ACO, and Don Berwick and Rick Fellons spent a day out with it.
Sure.
Discussing it. They were not issues around the operations so much as it was the policy structure.
Yeah. Well, you didn't need to do it.
Oh, we didn't. What we did instead was push Medicare Advantage hard.
Sure.
So go to full capitation
Yep.
kind of thing. We're growing that as fast as we can along the way. It's interesting, most of the savings come about because you avoid hospitalization.
Correct.
Most of the savings result when you manage upstream so that patients don't need a hospital or don't need an ED. That's a very large part of the savings, and they're wonderful. Better clinical outcomes, lower costs. I think that a lot of hospitals in the country are in for a really rude shock. It doesn't have to be the hospital who does it.
I know.
It could be a primary care group who's doing it, or some other third party.
I agree.
So you said primary care was successful. Mostly they took it out of the hides of the hospitals, and I think
course they did.
that is going to increase.
And from our standpoint, when we're out in the market in discussions with provider systems, delivery systems, and a hospital says they want to take risk but can't explain to us how they're going to manage it or what their primary care network looks like, we're out. But when a primary care group, a multi-specialty group that has a little bit of scale tells us they want to take some risk and they believe they have the tools to do it, we're listening. We have a much longer conversation with them. We've seen that pattern already.
And Bruce, the purpose of this session, the enablement of the startup community for this world, just imagine this for a minute. How many primary care doctors are writing $100 million checks for big EHR systems? Right? No way! They want the internet mobile app that gives them the information they need, when they need it, how they need it, text message me, Skype the answer, do this, do that. So the folks out there who are like, why is the healthcare IT sector in the Stone Ages? We're still talking about enterprise software standards from the 80s and 90s that, we've far surpassed in the internet economy. And we don't bring the internet economy to healthcare because why? We don't know. What I'm saying to you is there's now a valve. Those doctors are on the frontiers of this, that are getting that $80,000 check from Medicare. They want to buy that mobile app that allows them to get the text message that says your patient just showed up in the ER. You get 2 hours before they make an admission decision to get your butt in there and get that patient checked out, right? And then the hospital's saying, well, wait a minute. I don't have a mechanism to text message the primary care doctor. Now the hospital's on the defensive. And it's a fascinating system because you've got long enterprise systems operating in the same world where these internet nimble agile apps that just need a little bit of information to do a little bit of workflow want to operate. And the thing that's going to bring them together is the FHIR API. It's the FHIR API. For those of you who haven't been following this, I'm not there in the government anymore. The government has regulated. Finally, we've finished the job on interoperability. That the path to interoperability is that internet-level connectivity in the patient's hands, where the patient can push a button digitally to sync the dispatch app with the Intermountain portal. And the dispatch app doesn't have to have a 9-month sales cycle to convince Brent to buy him, because he doesn't have a deal with Brent. He's got to deal with the primary care doctor down the street. And all he has to do is connect that app, no fee, right? HIPAA says you can't charge the patient. It's got to be API enabled, so you're going to have to do it by stage 3 certified EHR. And wow, all of a sudden we've got patient data liquidity at internet scale. And the fascinating thing now in this enablement of opportunity is which community is going to be early adopters of the FHIR API. A lot of folks are going to wait to the very last minute to allow the internet switch to flip on. Or you're going to say, hey, I want that internet switch to flip today. And you're going to see this calendar year Epic, Cerner, Athena, McKesson, Allscripts, and Dr. Chrono publicly stated at the White House 3 weeks ago that they would ship this year to those institutions who wanted it the technical ability to flip that internet switch on, to allow a patient-designated app to connect to their health data. And that glue will bring this to life.
There's a question here. Go ahead.
No, I was going to add a Winberg GPS so you know how to find the best care for the doctor.
A Wenberg GPS, that's the app. Build the Wenberg GPS and you can be a billionaire saving $1 trillion in the healthcare delivery system. Go for it. Or maybe Intermountain will commercialize their variation reduction disclosure app and do it on every doctor in America, and that too would be the Wenberg GPS app. It'd be amazing.
You'll need some price transparency first, but
Physician accountability so we know how patients view their doctor.
See, the loop is coming together, bottom up, top down. Amen.
Mark, you want to talk a little bit about how application of what he just said, or?
yeah, I mean, I love the bottom-up concept. I mean, that's essentially what we're doing. And it feels a little different than the 90s to me. I was a young physician in the 90s, and it felt very top-down and authoritarian. So I think, you know, for this to really change, providers as well as patients have to feel enabled, and they have to feel like they're in control to some degree. So, you know, I think that's key for this to get adopted.
Okay. So great ideas, I guess. What are the barriers that have to be addressed? Are there any? I guess.
Of course.
Really, there are barriers? What's that about?
I'll let Brent react. I mean,
Brent?
you created the system. It took like 30 years of hard work for the system to get to the maturity that they got. They must have broken a lot of China along the way.
It's interesting. We were the weird guys out in Utah, you know, doing strange things, and then it turns out the world kind of moved into that path. We had time to fail towards success. I've watched other systems cover the same territory in 5 years. So it really picks up speed once you have an established path, an established model. I think the data transparency is not quite as simple as saying internet, in all honest truth.
I agree.
You mentioned the EHR3 idea. I think that the government's role in that has been as much a barrier as it's been an asset, in frank truth. But it is coming. I really like your idea of bottom up, that idea of democratizing it. Another thing to consider, one way of thinking about it, you can make a compelling argument that the healing professions were central to human society for as long as we have a written record for humanity. Earliest written records talk about healthcare. We find artifacts from Stone Age society showing that central role as well. Would have been the tribal shaman, by the way, not called a doctor, but same function. We also know that until about, minimum 1910, if you went to see a typical physician, your chances of survival went down. Seriously. As late as 1900 here in the United States, the most common therapy for any problem was bloodletting.
Yeah.
Second most common were purgatives, chemically induced vomiting and diarrhea. Wow. And the question to ask is, how is it that we were central to human society? Turns out there's a reason that the healing professions are called the caring professions. And people miss this all the time. Served on an IOM committee, the Performance Measures Committee, and an interesting fact, Anish, at least on the established empiric data, about 2 to 3% of patients will pay attention to directly applicable, easy to access ranking data when choosing a physician or a hospital.
That's it.
That's it. It depends a little bit on condition. So that's on stuff that are established conditions. People base it on relationships.
Yep.
And this caring aspect. So that's a potential barrier to that model. I think it will still take active professional leadership. I think it's members of the healing profession stepping up and making it work. It won't happen automatically, but it matches to our values so tightly. But it will still take that professional role to drive it ahead.
I actually agree with you 100%, but here's where the internet piece fits the way I'm describing it. By the way, is there a doctor in the room today who's in a Medicare ACO? Can we just put a face to someone who's actually in one?
We're negotiating on one right now to see if they'll do it the right way.
Really?
Yeah.
But let's just, so it's an interesting point. We're having this conversation about accountable care. The easiest program to sign up for that doesn't cost you anything and it's one-sided risk, and there are a bunch of doctors that are in the room, but not a single hand in this room went up. That's a little bit, whoa. Just pause for a moment. But let's assume for the sake of discussion, one hand is up. Let's just make one up. That empty chair right there is the ACO. Now, here's what I mean by that. Actually, let's talk about your neighborhood, Brent, because there's a Medicare ACO in Salt Lake owned by doctors, not owned by Intermountain. So let's go to the market you're operating in. Right now, that primary care doctor has all the incentive to help bring down the unnecessary cost because of the one-sided bet. They don't have access to your health records. Or if they do, it's, I'm sure, some convoluted process. I don't know. Let's just assume it's complicated. If they worked with the patient that had the internet button, sync my data, and they could access the information that from their last admission at the hospital back in so that they can help understand what happens next, and can incorporate some of that ranking you're describing, that 2 to 3%, if it's the primary care doctor in an ACO who's given the same list on behalf of their patient, maybe 70, 80%.
Turns out that that's the assumption that people have been making for
That's
about
an
the last
assumption.
50 years.
Yes.
And it has never been validated empirically across maybe 50 drugs.
Well,
So you have a little proof to do before you put that one forward.
Here's-
I'm going to demand some evidence that it would actually
Yeah.
work that way,
But
given the weight of the data.
when you visit the ACOs who took home savings,
Yeah.
and you ask those doctors, what did you do? Changing referral patterns was among the top 3 things they did.
But that was what the physicians did.
That's what I'm saying.
Okay.
I'm not talking about the patient.
Oh, all right.
Forgive me. I meant the I meant that chair that represents the proverbial doctor in Colorado that's
Fair
on a
enough.
risk
That's real.
contract.
That one's real.
I didn't mean the consumer.
I misunderstood.
I agree. The consumer, that's a separate question. But that chair that represents the doctor who's now in the ACO, who's not on your payroll and is not accruing any savings to you when they take advantage of the information and help to reduce the cost. They get the check from Medicare. They don't share that with you. So that's the disruptive force that's coming. It's the primary care doctor in small groups evolving to bigger groups, maybe, that armed with information and the health internet button with their patient's consent, that is organizing for this bottom-up change. Because that doctor could cut the deal with Prather, even if he has a hard time selling to the health system. That doctor might cut him in, and he has many, many more doctors to go after. Now, here's an interesting date. When do we think a majority of doctors in America will sign up for ACOs? There's a certain bipartisan piece of legislation that gives us a clue. Yes, sir. This guy's really smart. The MACRA legislation. What happened? A majority of Democrats and a majority of Republicans said, enough with the doc fix. Regular Joe doctors, primary care doctors. And what they said is the following very interesting decision tree. We're going to get rid of your doc fix and give you your money, for whatever, we're going to make you whole effectively. But if you stay in fee-for-service medicine, we're going to make your life hell. You're going to have to fill out thousands of charges, paper, quality measure, this.
It's not just hell, it cuts to rate increases too.
You got it. We are going to make your operating life as a standalone primary care doctor not all that fun.
So, Anish, you're saying as insurance companies we're making fee-for-service a little too easy?
Maybe you are, I don't know. But what I'm saying is the MACRA legislation is going to say to doctors, you have a decision to make. By 2019, when it actually kicks over, either you stay in fee-for-service and do all this stuff, or you flip over to an ACO and you do the ACO stuff. I wonder how many primary care doctors, whether their institution's sponsoring them or not, will choose the fee-for-service route. And if we know that's coming, 2019 is not that far off. Levitt Partners said that they estimate 100 million people will be in ACO arrangements on account of this legislation. I may misquote that number, but that's roughly, I think, what they were saying. And as a result, the race is whether or not people opt out of fee-for-service Medicare and opt in to Brent's Medicare Advantage alternative, which is another decision tree that the consumer will have. So you can see the chessboard moving in fascinating ways.
Well, it goes beyond that, Anish, and then I have another barrier to raise too.
Yep.
It's next gen ACO. We have
It's close to you.
Well, it turns out that it's very close to what we proposed earlier.
So when do you do it?
Well, it depends. We have a couple of structural policy issues. There are about 3 of them, and if Patrick and CMS is
Sort
willing
it
to
out.
do it, we do it tomorrow.
Wow.
And that means that close to 100% of all of the Medicare care that we deliver will bear full capitation. We really like that idea, by the way.
Society would like that. That would be
Yeah,
great.
It looks great. So back to the IT thing, though. There's another challenge that we face, and to explain it a little bit fully, it doesn't matter which EMR, Epic, Cerner, Athena Health, all of them, the majority of the data they collect are in English free text. In order to run those sorts of apps, I have to have it in a computable format. Turns out that NLP, natural language processing, still isn't ready for prime time. What we're working on, and others too, is developing a next-gen electronic medical record that flips the whole thing. The current generation were designed primarily for fee-for-service billing, just in passing. That's why most physicians hate them. They're not clinically natural. Designed to optimize fee-for-service billing, then they bolted on some clinical decision support. What if we designed one for clinical decision support? And I actually think it's the next big shift into true interoperability. It goes far beyond what we have today. We've run some experiments. We're getting over 95% semantic concepts, computable semantic concepts, and that's a game changer. It means that I have true interoperability. We built some of the first smart on-fire apps that are actually out there, as you know. I'm not sure it will be Fire. It will be something like Fire. I think you could push it a couple of layers, but that's just progress, isn't it? But it's clearly the direction it's heading.
And if you go to David and Mark, so here's the interesting question. Brent is like onto the most important subject for the entrepreneurs that are trying to live in this hybrid world. If you're an entrepreneur and you need patient data, you have 2 choices. Basically ignore it and try to get manual data entry to work around it, or like put up a whole shop somewhere where you have to like get scanned, faxed records and like basically re-enter everything, and that's the world of the extraction world. Wait for this next generation platform, which by the way, I would love for everybody to have your next generation platform yesterday.
Yeah.
It's not realistic in the fact that there's a huge installed footprint. So there's a middle step. What's the middle step? We spent about 20 years defining not the entire health record, but a minimum health record. All your meds, your lab results, your problem lists, your encounter summaries, who the doctors are on your care team, your smoking status, etc. These are 16 pieces of information where, Brett, the regulations define the text and the transmission standard. So the meds list that a consumer, if you log on today, or let's say you get to a stage 3 certified EHR, and if I logged on to the patient portal and I said, give me my meds list, even though the meds list running in the hospital is proprietary to the vendor that is there, it gets transformed when it comes to the portal, and it looks the same whether it's Epic, Cerner, Athena, or McKesson. So Brent, in the middle ground, they're in the stage 3 meaningful use regulation, which again, people in this room could adopt this year. There's no barrier to people adopting it this year. But if they did, then at least that bit of information can flow like a USB drive at internet scale this year. So my general statement is, I am all in with Brent's re-architecting of the EHR, because what his team is thinking about is absolutely the right end state for the delivery system. It's just going to take time to turn over the billions of dollars of infrastructure that we just put in. So what we're going to have to do is tweak the stuff we put in, and this Fire API on the minimum patient data set is coming. And again, the hospitals in this room have the choice to do it this year or wait until 2018. So for the entrepreneurs in this room, or the folks that want the community to be better off, in this market than others, you basically have to pitchforks to the hospitals and say, give me my Fire API this year. Because then the dispatches of the world and the others can start to do their thing, because Mark won't want the dispatch app to have to cut deals with every health system to do a custom interface with every one of their EHRs. It'll crush his business model. If he could one-click connect to pull the meds list, the problem list, and have it one connect with no marginal cost with every one of those systems, that would be awesome for him and every other entrepreneur in this room. And it's possible. To me, the biggest barrier, you asked, Bruce, it's this mental disbelief that that can't happen this year.
So,
It can.
Anish, just one other idea. One of the reasons that we chose to partner with Cerner is because they could
Do it.
show us a services-oriented architecture.
Yes, sir?
We didn't think Epic could. I'm not sure Medtronics can without all 3 years of hard work to get it up to that speed. So I think that there's a market working in there too along the way. It will get there.
I'm agnostic on all vendors. I make no positive, no comments on each. They're all great. But
Sounds like you're still at the government.
No. But spiritually, you're right. The market will react.
Yeah.
The market will react.
But that's where we're headed.
And how will David fit? He's got no regulatory requirements whatsoever on any of this data stuff. He could keep the patient's data hoarded up, locked under key, with no access to the dispatches of the world or whatever. I don't know where he
Well,
fits.
wait a minute, Anish. He doesn't have anything that I didn't give him.
That's true, but he's got the claims data. He's got the processing engines.
Well, so not so fast. There actually are some regulatory requirements around what we have to do with claims data and patient data and things like that, beyond just securing it.
But not to give it to the patient. You're not under any obligation to give it to your customers.
All right, I'm not exactly sure about that either, but we can talk about that.
You can voluntarily do it.
Yeah.
How about that, people? Pitchforks out for Canopy. Give me my data. Give me my data.
Well, what's unclear to us is whether consumers actually want to talk to their health insurers about healthcare, and whether we're actually a relevant source of healthcare data and healthcare information. And so one of the things we're going to advance in our business is again, if what we're really going to do is we're going to worry about insurance risk and hopefully empower the providers in our network to deal with clinical risk, then those conversations, you don't want to have those conversations with your insurance company. You want to have it with your provider. And so, we'll do the things we can to stimulate that. We'll also do things we can to get out of the way. And certainly make sure that as a company that needs to be really good at making sure everyone gets paid for delivering health care, we've got efficient structures in place to do that, regardless of what the payment mechanism is, whether it's straight fee for service, or whether it's a Medicare DRG or something like that, or whether it's a full capitation. So that's where our technology focus has to be, to make sure that we've got the flexibility to accommodate payment reform as the provider community kind of comes along the path. And I'll tell you, our experience, having been in multiple markets with this business now, is that markets have very, very different levels of maturity in terms of not only the provider's ability to manage risk using data and tools and process and things like that, but also simply their ability to deal with different types of reimbursement, some of which you would actually take for granted and assume that a market has the ability to do, but I'm telling you, they don't. They don't.
I've got another idea for you, Anish, and to David and Mark and Bruce. This is from observation. I know a fair bit about how you manage, for example, chronic diseases.
Yep.
And the structures, the processes you have to put in place for them, the decision support processes you have to have in place. They're fully understood, I think, within the profession, moderately complex. Anybody could do them at one level. The observation is that in every community where I've seen it work, there has always been a consolidator. Always. It's usually something that the independent physicians can tie into somehow, every time. In Indianapolis, it was Regan Street.
Yep.
Big IT group. A couple of places, in Grand Junction, it was the IP Model Physician Group.
Yep.
Interestingly enough. In our area, Intermountain is one of those consolidators. There's different organizations, but there's always a consolidator along the way.
So who do you think it's going to be?
Well, I think it's actually going to be many different kinds of organizations, and I think it's a real opportunity for people who want to step up and play that role. I think it's a critical role. I think that the health information exchanges have struggled a bit. I'm not sure that it's that kind of a cooperative approach. It seems the entrepreneurs have sometimes done a little better.
Here's an interesting question. What's the most popular healthcare data set downloaded by consumers in America? Which consolidator has the most popular healthcare data set that's downloadable? That is to say, my personal health data.
You're going to argue CMS.
Nope.
No?
I would love to. We tried with Blue Button, didn't have as many people as we wanted to use it. Who anybody want to guess? Anyone in the room? Which entity in the American economy had the most downloads for a patient healthcare data set? No, I would love for that to be the answer. True. Walmart.
Wow.
Walmart offered every consumer the ability to download their medication expense history data, which they gave to their accountants. I don't know, 3 million people, I think, at last count, hit it in the tax season. I don't know how many are going to hit it this season. It's got all their prescriptions and all the other medical expenses that are paid for in Walmart in their account.
At least for Walmart.
Of course. So here's the question. Let's go to Walgreens. Walgreens is paying patients 500 balance rewards points if the patient voluntarily connects a health data set to their Walgreens mobile app. How many million Americans have a Walgreens mobile app on their phone? Anybody? 20 million. 20 million. By the way, what was the killer feature that convinced them to download the Walgreens mobile app? Photo printing. So now, imagine a world where the Walgreens mobile app says, hey, under stage 3 meaningful use, which they're not going to use that word because that's lame, but they're going to say, hey, patient, we'll give you 500 balance rewards points if you sync with that ugly patient portal at your doctor's office in the hospital, which is ugly and gross and lame. Don't use it. We'll reward you. We'll log in on your behalf, and we'll give you alerts and reminders if there's things that are important for you. Wow. Interesting. And how much will Walgreens have to pay every hospital to get access to that API? Z-E-R-O. Z-E-R-O.
Let's back up a step.
How about that, Brett James?
They can't charge patients. They can't charge patients, but they can charge Walgreens.
No, so this is an interesting question. If you cut the Walgreens deal as an enterprise contract, if you did some kind of 9-month negotiation where they pay you and you do some medication adherence, for sure you will pay each other.
So you're saying patient downloads and they upload.
Well, they don't upload. The standard is, I'm going to get an alert. How many of you have Netflix? Okay. If you watch Netflix on Apple TV, you've seen the future of healthcare. Apple and Netflix did not sign a BAA, DIRSA, HIE, nothing. Somehow, you've given your credentials through Netflix, Apple into Netflix. Netflix says, gee, it looks like an Apple TV is requesting your account. They text message you. You enter a 4-digit code, and you sync the accounts. And the next thing you know, they're interoperable. And if ever Apple is spamming you inappropriately because they're misusing the knowledge they have of your rental history, you can go to netflix.com/settings and push the depermission button. It kind of sounds like our Internet Privacy Bill of Rights, Phil Weiser. Where's my brother? Where's my brother? Come on, brother. So now we're giving people control. So if the consumer can sync the Apple TV or the Xbox with their Netflix, you think they're going to have a hard time syncing their Walgreens to the convoluted portal that they don't want to log into? Right.
And of course, you're using Walgreens just
as an example. Right? This is the most exciting time to be in healthcare as an entrepreneur because the bottom up shall rise and we will make the healthcare delivery system work for the people that we love. Because that primary care doctor in that empty chair that doesn't exist in Colorado, who actually believes in this stuff and is embracing it, they're going to call Mark and say, dude, you got to get this stuff out of the ER. Please, Mark, I'm begging you. And he's going to say, I'll take your share of the upside. Let's go, brother. And boom, they're off to the races. I need the data. Oh, sync. Got it. Even the people that his dispatch staff will do it, they'll sit with the patient at the dispatch. Hey, can you sync the account? I'll do it with you in front. You don't even have a smartphone, patient. Let's do it together.
So with that.
How about that, Bruce?
With that, right on, yeah. Wait, noticing everybody's downloading the Walgreens app.
check your wallets.
That's right. We've got about 10 minutes. So let's see if there's some questions. Let's start right here with this gentleman.
The idea that you're moving from data to information to knowledge to wisdom. Why didn't David Brailer say with the EHR incentives, let's take these 16 things and instead of having 139 different vendors, come up with 139 different ways to communicate?
I won't speak for Dr. Brailer. I have high regard and great respect for Dr. Brailer. And I think if you looked at where we are today, it would not have happened but for the seeds he planted. So this happens to be an area where Republicans and Democrats, entrepreneurs, incumbents, have found a way to come together. And yes, it's got warts. The systems are annoying and they're frustrating and having to click through all these decisional, there's all these issues. But we've reached a place that maybe it could have been accelerated a few years, but I think it did take the time it needed to take. But once you've opened up the hose to the data, the level of creativity on what people are doing on the other end of that hose will be astronomical. I was in the Bay Area for the JP Morgan thing, and I was meeting some of the cool entrepreneurs. I was like, so how are you getting patient, they get a cool coaching app, you're teaching people things that they should do. Show me how you're actually seeing today. Oh, here's my interoperability with unnamed vendor. The patient logs into the portal, takes an iPhone screenshot of their account and uploads it to our app. Our staff then have to recode it on our end, and then it fuels our system. Interoperability, okay? So the minute that API rule is in place, and the first institution in Colorado that allows an app to connect, let's see how unbelievably exciting it is. The breadth of creativity, the physician enthusiasm, all the stuff that'll happen when they can connect. Just the question is right now, is there a single person in this room who has data, PHI, that is exposing it via the FHIR API, the secure API? The standards have been designed. And Brent has underwritten a lot, not him, but his colleagues at Intermountain have been sponsors. Stan has underwritten a lot of the IT, the plumbing. Intermountain is to be a hero in this story. But is there a single provider in this room that has allowed any patient-designated app to connect to the records data? Anyone in this room? Right.
Nope.
Yet, they will be live this year in other parts of the country at very low marginal cost because the internet transaction security structures are not that expensive.
So what you're saying is you can't put an API on a paper medical record?
Hey man, Humana is giving patient claims data over an API. They just haven't exposed it yet to patient-designated apps, but the CEO got religion, so he gave the speech at HIMSS and said, I want to go all into the APIs. His team published, I think at last count, they're up to 22 APIs. A patient can change their primary care doctor through the API. They can get their claims history through the API. So people are getting the religion. He did it on his own, didn't he? He wasn't regulated to do it. He did it on his own.
It's worth noting that the underlying architecture, the buzzword for it is services-oriented architectures.
Yep.
And on the Gartner hype cycle, it's now come into a stable range.
Mature. Yep.
And it will be how fast can the major data vendors that supply the services we use make those open. I can tell you that the ones that we deal with can.
Yeah, Cerner's all in for sure.
Yeah, well, they can do it already. And so, I think you're right. This is going to be our future. I mean, it's going to be app development heaven, basically.
Let's see, other questions out there? There's a question here. Here, she's bringing the microphone too.
She's part of our ex-government mafia in the room.
There you go.
Yeah, so I'm all in with you on the internet vision, but I want to understand better the certification and security
Yes.
you envision so that, someone I don't want to isn't seeing my data.
Yeah. So the about 2 years ago, well, actually in 2010, the Mitch Kapor, who was the father of Lotus, gave this speech about the future of the health internet. And he gave this speech in an audience at this Harvard summit on apps, and the coming healthcare app revolution. And it was obvious in it was this fall of 2009, we had reserved about $60 million of R&D money to kind of get to where his question was, which is how do we leapfrog the current infrastructure? So ONC awarded a team at Harvard a $15 million grant to look at the technical standards for the health internet. And that is exactly what Brent's describing. The word smart on FHIR. I'm explaining. In Smart on FHIR, there is a security standard that had never been in place at HL7. And it's a security standard to authorize applications for access to specific patient health resources. It logs and tracks Once the app is permissioned, it tracks and logs anytime the app API is hit, where it's hit, what it's hit for, etc. All audit logged and tracked. So the regulation, the Meaningful Use Stage 3 regulation, definitely envisions a security layer. And what the industry has done, and I've been involved in this effort, Epic, Cerner, Athena McKesson, and Brent's colleagues funded something called the Argonaut Project, which is an open source testing body that is marrying the security API with the content FHIR API, and the combination of the two, FHIR plus OAuth 2, is what's being tested today. Epic, Cerner, Athena, all of them have posted their version of the server with the security layer so that any app developer at argonautproject.org can log in, hit the API, and test. Carm Huntress is in the room from RX Review. Carm was the first cool kid app that joined the Argonaut project. And how much did you pay for that, Carm? Zero. So it's free for everybody. And in 7 days, his IT team demonstrated that his application could run on the Smart on Fire specs. And so now he's blossoming as this unbelievably cool entrepreneur. And so the security specs are being actively tested in the way that they're supposed to be. You hit the server. If you see a problem, you give feedback to the standard staff. HL7 is funded with engineers to make changes. The community is engaged. It's that real-world feedback that's coming in. And finally, ONC has an active policy team with the public's involvement, a committee focused on security of the API, and all the documentation is published at healthit.gov. Just go to the API security team, and you'll see their recommendations. So the ONC has asked that an API supplier, that is the publisher of the data via the API, which is where the security risks sit, has to certify their app under the certification and testing regulation. So I would say in the next few weeks, ONC will publish the security specifications and basically how to test the API, and every vendor will start to see the separation of the wheat from the chaff. The vendors that go through certification will go through a rigorous NIST-endorsed process to make sure that they've been hit everywhere from Sunday to make sure it's working. And only certified API modules will be likely purchased by Brent and his colleagues because they wouldn't take that risk otherwise.
So just to add a little detail to it, Anish.
Yeah.
We have two different levels of security here. The first is the idea of transmission security, storage and transmission security, which is what we're describing. If I get it right, the fact that a patient chooses to upload their PHI to
There's no HIPAA protection for that.
Yeah, well, it doesn't. It's the patient chose to do it. They
Correct.
have autonomous rights to do that, but the fact that they chose to do it is how we get around the ethical issues of sharing PHI.
Correct.
The patient initiated it. And
If
so
the
that's
patient wants to designate the app to dispatch, and dispatch is some shady fly-by-night thing that doesn't have security standards, but the patient opted in to do it, if Brent was the source of the data, his liability on the HIPAA security rule stops at the secure transmission to the app the patient chose.
I'm sorry, I might be asking a different question. But how does the patient know which app to trust?
That's why we want Phil Weiser involved. Because we have when Bruce asked the question about barriers, today there is no regulatory framework for patient apps. Okay? Now, Apple, to its credit, has voluntarily added a requirement. If you're a developer that wants to use HealthKit, you must use the model privacy notice that ONC came forward with. So it's an example of an industry voluntary, self-regulatory framework. And Phil, where can they get a copy of our white paper?
On the Silicon Flatirons website.
Go to the Silicon Flatirons website, and you will read a beautifully written paper by one of Phil's brilliant lawyers that encapsulates this policy hole that needs thinking and involvement to address. And rest assured, there'll be a lot of attention on that.
There's one more question up here.
Recently, specifically in CIO magazine, there have been some articles about blockchain and monetization opportunities within healthcare. Can you comment a little bit about what you think the blockchain opportunities see in securitization of health data?
It is a very interesting proposition on how to assemble one record across many portals, and this sort of decentralized aggregation of my health records into one blockchain trail so that, if a doctor accesses my record, that doctor wants to know that that record wasn't tampered with. So me as the patient, I didn't manually go in there and rewrite stuff. So the blockchain could attest to the fact that that particular patient-mediated record had not been tampered with. So you could have that kind of ledger. It wouldn't be tied to the currency. It's tied to the framework. If you look at John Halamka publishes a wonderful blog. It's called Life as a Healthcare CIO. This morning, he published a beautiful page and a half on his musings on the blockchain for health records with input from David McCauley at Cerner and Arian Malik at McKesson. I'd encourage you to read it.
All right. With that, it's 3:45. I think I want to thank the panel. We've got a 15-minute break, and then at 4 o'clock we'll have the next program on the precision medicine revolution. Thanks very much.
Thank you, Bruce.
I don't know either, Matt, but I'm curious. I wonder if you could say, we'll work with you to import our thinking into your open source world and see what that looks like. I mean, they may not like you. I don't know what it looks like.
Positions are trying to base facilities, and so we're struggling. Where you get everything decisions on
CDS hooks?
Yeah, maybe. The way that we're currently is trying to get it on the next one.
Well, Cerner's supporting the CDS hooks open source model, so non-Cerner EHRs could run the CDS hooks. Harm is testing it.
I know, but that's we are also running build interfaces.
You have to?
It'd be interface. That's, of course, it's always got a couple of steps.
Maybe you could sell insights as a service.
Well, believe it or not, the one that's really running is you do. Yeah. Outside the U.S. Holy cow, the demand is for probably maybe if we can survive it.
That'd be amazing.
Well, what it means is think of yourself in inventory. You got a crowd. Imagine 22 hospitals. Imagine 2,500.
No, I get it.
All running the same point of care.
You would
Concept data capture.
You would crush it. Every MA plan. Oh, I love it. I'd love to help you to support that.
The decision support part often requires an upgrade of brain.
Yeah, I know. So the question is, what share of
By the way, you're going to be a good friend.
Yeah, it's a little spicy.
Two good friends going at each other. Larry Gold,
Larry Gold,
a wonderful entrepreneur.
How's it going? Nice to see you. Yeah, yep.
Love to come out and guys. Trying to take a bunch of piece from academic centers and high performing business like yours to drive that into the community health system. Yeah, we'd love that.
Probably the way to do it is through state.
Is the best play.
Yeah, or it's hard to say. We'll have to understand exactly what it would be. The guy who runs our pharmacy piece, but he'll be an internal organizational guy, is Eric Cantley.
Okay.
And then the guy who runs our entrepreneurial development side is George Hamilton. He runs out of our CFO's office.
Okay.
Right? We're doing a lot of development hard.
George is the outgoing CEO?
No, George, the outgoing CEO is Charles Sorensen. George Hamilton runs the business office, where we partner with various groups with our service shop. There's Savvy Sherpa building these tracking devices, patient monitors, testing our hospitals about they can recognize who you are by your walking gait. And as people recover from surgery, you can tell your speed, everything, how you're walking. So, George coordinates most of those. He has have to just figure out how to hook it up. All right? That sounds good. So if you email me, I'll give you the proper rundown saying, well, here's the guys who might actually know what's going on.
Great. This is my CEO, Carm.
Hey, I just really enjoyed your
Thank you.
your points. Fantastic.
You know, our niche is basically spawn off of Alley's school. We can kind of
Bring it back in
be
here.
academic.
Little right out, a little academic. No, that's good.
But on the other hand, it's where the world is going.
It's aspirational, but it's directionally the right
What is
way.
the name of your intervention? I think it's using predictive-based models.
It's a little control. And it's like 3 pages long.
Can I email you for it?
Sure. I'll send it along. You'll see it's got a lot of detail, but it'll give you the right feel for it. There are these 3 big classes. So identify caregiver utilizers. Turns out that about less than 15% of them are chronic long term. The rest are episodic. Identify people who are likely to be utilizers in the future. That's predictive analytics job. And act financial behavior. Which is get after the big drivers of the behavior category, which is the biggest category. Those are probably, well, the interesting group is groups like, what's the name of that? It's in Boston. Remember in just a sec, starts with 9. They take health coaches to work with Medicare, medicated other people. They have their self-management scores, right? And this IORA, and it's really kind of interesting to see what they can do to teach people to manage their own health. I used to think you'd have to do it through the high schools, basically. The thing is that the literature really shows an impact. There's a direct correlation with high school graduation and college graduation. I don't think it's the type of graduation.
That's interesting because you look at Medicaid in every state, 75-80% spends behavioral health and pregnancy, right? Both of those could be correlated with high school education.
Well, yeah, 6 seems like a list. Now there are other lists, but you get the general idea. That's the one that came out of the AMA, and I like it. But others, they're all similar. They're all basically the same. But you have more leverage there than you have in care delivery. I mean, you get more for a dollar spent in education than you get by spending in care delivery.
It's early and
Yeah, but it's long. It's got a 20-year lead time. But IORA showed that they train up these health coaches. They're high school graduates, so not a lot of education, have a special training program, and then assign them 2 or 3 or 4 Medicaid patients they work on. Make sure they take their meds every day, make sure they get to appointments, so make sure they're doing whatever. And, I don't think they're taking a risk. They have it on a risk contract. But they look to showing some pretty nice data. See, but that's one hotspotting strategy. Another hotspotting strategy, getting the homeless into housing. That was done here in Denver, which is really interesting. Yeah, and so there's just a series of these things that people have done, and I'm sure that there are a lot more that you can add.
There's a really incredible organization here called Mental Health Center in Denver that has been taking full risk on behavioral health medication members for decades. And it's incredibly successful. We're working on a pilot with them to take some of that content and platform. But these guys are just incredible.
You know, that happened to us too. The state shifted all of its Medicaid into Medicaid ACO. And we quietly were big enough that if we directly supported it, sometimes schools would for backlash, but we quietly supported it. So now we're full risk on all of our Medicaid. So we like that.
It's not a lot of places that can do that and make money.
Well, yeah, it also makes the cost of Medicaid controllable and predictable for the state, which is why the state wants to work. It seems to me the senator named Dan Lewis put it together.
How are you addressing the FC quality issue?
Beats me. I have to go ask. I just don't know.
That's the one that we're...
Right now, I think it's a better clinical outcome, so we just do what I suspect. Just pay for it, because we tend to react that way. If it's got a clear clinical improvement, we tend to
Most amount of your members stick around. That would make sense.
Even if they didn't, as long as they're cycling in and cycling out, we'll get as many coming in as we have going out, so it's still worth doing.
Right. And systemically, it's the right thing to do.
It is the right thing.
Because at the end of the day, CMS is the ultimate reinsurer.
Yeah. So, you know, our whole idea is that these run the capitation office because we feel we know how to manage kids. And the waste levels are so high, and when you're capitated, all of the savings come back to your organization. So this year, well, we've taken about 13% of our total cost of operations. We've had some of the most robust operating margins we've ever had. We just released an insurance plan where we guarantee a maximum 4% per year rate increase for the next 3 years to employers.
There's a lot of business.
What it means is our chief competition is for profits in the state.
So it's regions that you're worried about.
Not regions. I'm talking about Columbia HCA and their associated networks. Now, I believe what will happen, this guy who's sitting next to me is actually very decisive. I believe it's going to change the role of insurance companies. So I chair the board for High Value Healthcare Collaborative, 14 big integrated systems, all of us heading down the shoulder about solutions. In just a month, we can drive enough of this all by ourselves. So, and Anish was describing models where they accepted as given the current fragmented professional care systems.
That's not your experience.
Saying, hey, wait, it's all shifting into team-based care. It's no longer going to be fragmented. I think we can do that with, I'm not sure you can do it with an app. It sure makes good things happen, right? I'm not sure. But I think that the world is moving into that idea of team-based care and coordinated systems of care.
That's why you're seeing so many providers that don't plan.
Yeah, so it'll be interesting to see how it all plays out.
Is there any sort of, intermountain doing an XG sort of model and commercializing this in some broader way?
It's called Center Innovations. There's also this thing that we have out in the business office in our transformation lab, is what we call it internally. But they've got a bunch of them running. Some of them are just cool. It's so big.
There was, at JP Morgan, there's something about leadership academy or something that's emerging.
That's going to be over associated with my group. He's going to purchase a lead that was to step down as our CEO in October, just to train up the next generation of leaders. We're building a new building for it, so we've got a great chance there. It's really interesting time, to say the least. You know, the funny thing is we took our first port over to Cerner, which was our hyperbilirubinemia and the newborn app, and we did it as more on fire, and we put it in the public domain as open source, and nobody took it up. And the reason is most of them they didn't have the SOA infrastructure. They could put it on fire to the point where they fast. It's a sweet little app. I mean, it's
So my wife is going to
Yep.
ask for his. Yes, exactly.
Thanks.
Jeffrey Nathan's we're a digital health ecosystem. And we'd love to get in the car. We're having a summit in 6 times. I'd like to get someone like yourself to talk about what you're doing in innovation. Do I do this one? That's for you. That's my car. This is Leah Bradish. I will reach out to you. I've talked to you. You work with him?
Oh, yes. We have a great fun time with him. Yesterday evening.
So I heard he was in charge of innovation. Is that true?
Well, we call our transformation lab. You can see him because he's our most intuitive member of our team. He's the CFO, which is kind of cool.
I will reach out to you.
Thank you. Yeah, I'm going to be another good choice. Yes.
Enjoy your panel.
All right, if I could ask people to have a seat, and I have a few folks still coming up to the panel. It's okay. We have a good reception outside, an unbelievable crowd. The good news is there will be another break coming up after this discussion, and then we will go to our final panel. We have an all-star panel here like the last one and the one to come. Sitting in Elijah's chair here is Larry Gold. Melody Harris is working for Qualcomm, but is a Coloradan.
True.
And so she does healthcare IT at Qualcomm here in Colorado. Carm Huntress, I think, has already been introduced by Anish, a great entrepreneur here locally, building a company. Eris is the president of BioVista. We'll hear a little about his company, his views. And finally, one of our grads from Colorado Law, David St. John Larkin. And we have a few of our grads here who've come in recently. This is a phenomenal area, healthcare, as I've mentioned. And this area we're going to talk about now is the precision medical revolution. People have heard a lot about precision medicine. It's one of those terms like the Internet of Things that gets used to mean a lot of different things by different people. And so one of the basic questions that we have talked about here in the panel and want to start with is how do we define precision medicine? Because, like I said, lots of people use the term differently. To get us started, one of my really great friends here, Dr. Gold, you are building a company that will be part of this effort. How do you see this concept of precision medicine? How do you define it?
The definition of precision medicine used to be, and still is in some places, we will sequence your DNA and we will tell you stuff you need to know, and we will use that the way that you use anatomy in other ways.
23andMe?
For example, yes, 23andMe. And now many others are jumping in. And so this morning, because we had all these discussions about what do we mean by this, I looked up in Wikipedia that's what you do. I looked up the word omics, like genomics and proteomics and lipidomics and metabolomics and omics. There are 20 of them. And it turns out it's not very well defined. It means basically measure a lot of stuff. So personalized medicine will be driven by measuring a lot of stuff, and then you'll say something smart from those measurements that is actionable. And for me, the sad part, since I don't do genomics, we do proteomics, we made a decision 20 years ago when we started doing this that evidence-based medicine or personalized medicine or whatever the word is will in the end be driven by something that changes as your health status changes. So I think there will be a movement where you will do genomics the same way you do your weight and your height and your eyesight and your whatever, and that'll be part of your anatomy. And then when you are really living, as opposed to at birth, when you're sort of starting, these things that change, these other omicses, will become part of the way you monitor how you're doing. So for me, precision medicine is the imposition of omics measurements of all kinds into docs and healthcare systems thinking about, and patients thinking about how you're doing.
Melanie?
I would agree. It's got to be broader. We're working on projects that start far more rudimentary than genomics, for sure, dealing with things as simple as your own heart rate, measuring constantly your own heart rate, your blood glucose, those types of things that we're feeding in on a regular basis into a database system that then is reading information back to the individual patient. That to us is precision medicine. So it's pretty broad. It's certainly not just around genomics.
Carl?
Yeah, I mean, I agree. I think spot on in terms of understanding the omics of whatever may be going on for an individual, and then tailoring therapies for that. You could take the context slightly further and think about socioeconomic factors, things that, environmental, and really tailoring it. Part of our work at RX Review is doing and understanding that complete context. We sort of say that the patient-centered view of what we're talking about, and there's tremendous challenges today in sorting and understanding all this data to make these sort of actionable insights. But it's bringing that whole context of a patient from a patient-centered view and then tailoring precise therapies based on that.
That's great. Lars. So when I'm sick, I go to the doctor and sit down with the doctor, and the doctor does a whole bunch of things and asks me a whole bunch of questions, and then they give me a therapy, a drug, or an approach, and that's tailored to me based on the best information that that doctor has about me at that point in time. Isn't that personalized or precision medicine? It is. And what's changing, and it's making it the hottest thing in healthcare among others today, is the degree of granularity and the amazing added information that the doctor can use in order to improve on that delta. But at the end of the day, precision medicine or personalized medicine today is exactly the same, or what it will be in the future, as has been since Hippocrates' time. The only thing that has changed is the cool tools that we have to inform this just a little bit more. But let us not delude ourselves that it is the be-all and end-all.
David.
So I'll have to confess that when I first heard the term precision medicine, I thought it meant medicine without an error rate. and I thought, wow, what a wonderful thing. We are finally there. But I don't have anything further to add other than what everyone else
Kind of
said.
like the end of history.
Right.
So Bob Kocher, who's been at this conference several times before, has predicted, and in his analogy here is the human genome effort circa 1999, that the precision medicine revolution is more hype than reality. And he says at this point, the cost to do robust, intensive data collection along the lines that are talked about here, including genetic sequencing, is quite substantial to do it at scale, and not necessarily the best bang for your buck in terms of healthcare improvements. So that's one view that puts this further out. What are your senses of timing? At what point do the 10x improvements from these richer data sources begin to actually take hold? And is it a near-term or a long-term project? And let me start again with Larry over here.
Well, I think that if you were, this is a question of clinical data completely, and everyone who's building an omics capacity, whether it's us or others, it doesn't matter, including the genomics guys, people, everyone is trying to do collection of clinical data. It's pretty simple. I'll give you an example, an example of where genomics will work eventually. So, and I don't like giving those because I think it's such horseshit, but never mind, just sharing. Tumors are very mutagenic compared to the rest of the tissues in your body. So when you're born, you have a certain genome, and later when you die, you have more or less the same genome, because the mutation rate during all those replications of cells in your body is low. Tumors, if they have a major biology that I think drives what tumors do, they have a very high mutation rate. So when you sequence the genome of your tumor, if you should be so unlucky to have one, there are lots of changes that are in that DNA compared to the other cells in your body. And this has become the cottage industry for the value of the genome sequencing in medicine. Because, and the idea is, wow, we'll figure out what mutations are driving what tumors, and we will treat based on those mutations. And that is a profoundly good idea. It would be an even better idea if all of the tumors that we call lung tumors or prostate or breast or ovarian or whatever it is, if they all were driven by the same mutation. That would be nice. But of course, that's not true. It turns out to be more complicated. And it's so complicated that it's created yet another hype, in Bob's language. It's a cottage industry. Every hospital in the United States that thinks it's a big oncology hospital has built their own version of doing this And patients look and they say, oh, I've got a mutation in KRAS, I should be treated by blah, blah, blah. But in fact, the evidence so far, it's early, is that the treatments that are guided by that genomic information are only marginally better than what you see. They are better. It's not, it is the poster child of genomics as evidence-based medicine. But the point is, for that example, is not whether it's good or bad. It comes from clinical observation. You measure stuff, you do an experiment, and you look at the response.
If anyone on the panel saw, there was a New York Times article, I believe it was about the BRCA gene associated with breast cancer, and this debate that someone was having with their doctors of whether they needed a preemptive mastectomy right away, and it was almost about to happen until she finally talked to a geneticist who said, this is crazy. There's no reason you necessarily this moment need to have this, because the room for misunderstanding is still great in this. And so I guess I'll now double down on the question. A, what's the timeline? And B, as we're along this timeline, how much room is there for error of people over-interpreting, let's say, genetic information without a lot of evidence to back it up? Anyone want to take on next here? What's that? You want to? All right. Not all at once.
So,
Eric, go for it.
Eeny, meeny, miny, moe, it landed, I ended up with a straw. So just to build on what Larry was saying, it's just a fascinating number. Alzheimer's disease. And I was reading the other day that to date, there have been, in our ongoing, over 400 GWAS, genome-wide association studies for Alzheimer's disease. You would have thought that with all of that horsepower, this would be part of history now, let alone cancer. So how could it be? And Larry absolutely spot on alluded to one of the issues. You have this mutation rate and these changes that you can detect or are too late in detecting or you just missed in the genome. And so one of the things that I've been fascinated about is the flip side of precision medicine, which is imprecision medicine. And what on earth do I mean by that? So one of the poster children of precision medicine is cystic fibrosis. Because there is a gene in cystic fibrosis that occurs in, 4 to 8% of patients, and there's a drug that targets that specific gene and that defect, and when you do that, you effectively cure the disease. But then, this other group figured out that if you actually go after a protein that is not mutated, it's just hyperventilating when the mutation is happening, and you fix that protein, then you actually fix the cystic fibrosis no matter what the mutation is. That's incredible. And this has led to this discussion of these corrective mechanisms that restore the balance when the genetics go wrong. So we're focusing all of the effort and all of the debate on the precise change that happens, and we're ignoring the native ability of the body to try to fix itself at the molecular level. And whenever this has been looked at, triple-negative breast cancer, one of the poster children of precision medicine, melanoma with some of the next-generation immunodrugs and checkpoint inhibitors, cystic fibrosis, the ultimate in precision medicine fix-up. What has been found is that these corrections that have to do with proteins and genes that would never be found by our typical omics approaches, if you target those imprecise areas, you end up with fantastic fixes. So in answer to the question, the timeline, just to circle all the way back, I think that we have more than enough technology. I think we have more than enough brain power to do it. It's just asking the right question in the right way. And that's just a matter of will, not time. Carl?
So I see this problem in kind of two ways. One is kind of where we are in sort of the value continuum. And so, we're still really in early days of understanding sort of the payment reform and value-based mechanisms that exist today. And well, with a lot of these tests and longitudinal, whether it's proteomics or genome sequencing, they're still really expensive. And so if you want to get to really complete, I think there are companies, I think one just announced in Boston, they've got a $1,000 DNA test now that gives you complete genome. And so, you've got this one challenge where, well, even if it's $1,000, right? How do we derive value out of that to prevent disease or to cure disease? And that's a really big problem. I was at the Lake Nona conference in Florida a few weeks ago, and the CEO of Foundation Medicine's there, and they'll genotype a tumor, and it's like a couple $1,000s. This is a company doing $100 million a year, but guess what? Only half of their tests get reimbursed by payers. And so until we can sort out the value equation and really understand, this is a test worth doing, it gives me reimbursement, and there's a derivative problem of this in that we are now in this place where there's confusion from the payer community around, oh, well, actually, this breast cancer gene is actually driving ovarian cancer, and the payer says, well, and you say, okay, I want to do a targeted breast cancer drug for ovarian, and the payer says, no, I'm not going to pay for that because you don't have breast cancer, even though that's the problem that's going on. So there's sort of that's one big chunk of how quickly we can move to get to this endpoint and this stuff actually providing value. And then I think the second problem is really about, I think we're heading into sort of the land of discovery and information overload, and then it'll resolve. And so if you think about companies like Nant Health that are trying to do the entire cascade from DNA to RNA to protein expression, the amount of data that you're producing, I mean, it's terabytes of data for a single individual patient. And sorting out and understanding that, and then really understanding the mechanisms, are still a lot of like the immunotherapies, like they're still trying to even understand, well, how the heck is this actually working? And it's still in that early phase. So I think we've got to go through this, we've got to start to solve the value question around these type of omic tests. And then I think the second piece is really sorting out the data problem that we're in front of.
So Melody, you're working on building the underlying infrastructure because all that data will have to be captured, collected, and stored, right. And then we have to figure out which is the most valuable. How do you handicap the time frame of how this all proceeds?
Well, it's interesting because I think a lot of folks in this room think about healthcare and these innovations and revolutions on a United States level. We're doing it on a global level. And to build an infrastructure that works across the myriad of privacy and security laws across the globe is a really challenging thing. And so getting right, and I appreciate the earlier panel's conversation about the security aspect of it, and Fire API may give us some leg up. We'll see if it gets, we went through Blue Button, so let's hope that Fire API works out a little differently. But the privacy aspect cannot be underestimated. So Phil, apparently you're going to fix that gap for us.
Apparently so.
But in seeing, we've been doing it not at an omics kind of level, trying to bring the data infrastructure to precision-light medicine for over a decade now. And we have come a fraction of the way. So my handicapping of the timeline is we may get to some of the precision-light infrastructure and actual usage and value within the next decade. True genomics is a long way off still, in my opinion.
So David, I want to start with you with the next question that comes from this that we will need to be out front, which is the basic ethical issue in that when patients go to the hospital and give a blood sample, the hospital will be in a position to capture lots of data about that patient that it can run analytics on, associating qualities with that patient and whatever omics is being measured. What's the right ethical privacy framework in your view? You could de-identify this all. You could de-identify it with a break the lock and get it back sort of thing, a la the recent iPhone episode. You could make the lock unbreakable in theory, maybe not in practice. Or you could basically tell the patient, hey, we want you to surrender all your privacy because we think it's better for you and for us just to have it all out there, and we're going to be able to know that you're in this category, and we'll be able to tell you monthly, yearly, here's what we know about your conditions. That's an architecture
that in theory you set it up, you try to hardwire it, and the data gets developed and used in a certain way. If you were the chief legal counsel for UC Health, how do you think about setting up the architecture here? What data framework makes sense to you?
Well, so my first concern, I guess, would be the consent issue, and I can't get somebody to consent to something they don't know. And this is not an easy situation or set of possibilities to describe to somebody in a short and concrete way, particularly if it's just a blood draw, for instance, or some sort of non-invasive procedure. They're there for maybe 5 to 15 minutes. So, one way that I think what we'd have to focus on first would be, what is the set of options that we might describe if we can present some options to someone, where we give them the choice and the possibility of a consent for each of those options.
Would the option include, don't keep my data at all?
I think it would have to, in that because we don't have a regulatory framework that's permitting us to take it against somebody's consent, or that would the consequence or the flip side of that would be
Henrietta Lacks, right? Isn't that the flip side?
Yeah. So I think that what we really want to do is without a mandate one way or the other for whether we can or cannot take it. I think that the best policy in my mind would be to put the power into the person, give them the ability to consent to the extraction, the storage of it. But I think the problem is that maybe at first we wouldn't have very large of a data set, but this is at scale, and if other institutions across the U.S. internationally are doing the same thing, I would think that we would at some point start to gather a larger and larger data set, and hopefully get by those issues found by those people that don't consent.
So these are really rich issues, and the lawyers in the panel can totally geek out on them. Melody knows this really well. There's a different set of regimes, opt-in or opt-out. I often confuse which one's which, but I believe opt-out is unless you tell us otherwise, we're keeping your data. And opt-in says, we're not going to keep your data unless you give us permission. It turns out, because people tend to be lazy, if you have an opt-in regime and you're the hospital, it's not that easy generally to get the data unless you have this really great procedure that happens for all of us with HIPAA, which is the first thing they do before they treat you is they make you surrender all your data. So they kind of turn the opt-in on its head. But usually opt-in is hard to get the data, and opt-out, very few people actually do, and so the data generally gets in. And then you've made another point I want to put on the table, which is the so-called informed consent idea. And Melanie, here's my problem with this is, how do you consent to something when you really don't know what the impact is? So I'm here sitting literally with a free 23andMe kit. I'm not sure if I want it.
It doesn't matter. It's not worth anything. It's okay.
So there's that too. But what if I could know using proteomics about my future health? You might be at a certain age.
Can I interrupt?
Yeah.
So the thing that's so amazing about this, we're talking about, I want to use the word I used last time with you. We're talking about fucking dying, all right? So we're not talking about whether you're wearing red shoes or blue shoes or whether you bought a pink sweater on Amazon. We're talking about death. So the question is, will these ethical issues be a little different when you sit around and you think, holy moly, I don't have to die of some terrible disease. I can die at the age of 75. I'm 74 now, so I'd like to say 82 would be nice. But I can die pleasantly in the middle of the night. I can just be dead instead of suffering for the next 20 years. We're not talking about consumerism of the normal kind. We're talking about health care. And I think what's going to happen is we're going to keep having these discussions in the United States, and it's going to be stupid, I think. Important, but stupid. And while we're waiting in the United Kingdom, where we're working, we are working in Oxford with a really great medical group, and it's the NHS. And they're trying to solve a big problem called 80 million people being healthier. They're trying to take care of the frail elderly. How about if you can, instead of being the frail elderly, you can be okay? That's a good idea. We're talking about health. And I think it changes the discussion. It should. If it doesn't, shame on us.
Yeah, well, most of the studies have shown, when they ask consumers, are you going to share your data if it would improve care. I mean, that's very high, 80, I've seen as high as 80, 90%. And that's a very different approach than, do you want to share your banking information or something? But if people know it influences their health and is sort of for the greater good, and it's as long as it's kept anonymous, there's big consent there, I think. And the good news, from my perspective around that is that's more than enough data. If you got that much, data going around and people sharing and exchanging it, you can do a lot of incredible things with that data. So it's good to see that type of consumer response and interest in being open around that.
And I think similar to that last discussion, we can imagine there's a world where there's a technological response to consent, so that we can encrypt the results. It could still be possible to protect the privacy of that individual to have a consent right down the road, and consent for different sorts of tests maybe. But maybe not consent for an insurance company getting that data or somebody like that.
The challenge, though, is that we don't know yet all of the aspects of how we want to use the data, right? And so it's back to this question of how do you give an appropriate informed consent when you don't even know yet how you want to do the data, use the data. And we have this issue all the time, and we try to grapple with it through the concept of de-identification. But the challenge with that, again, on a global basis, is that different countries have different standards as to what is de-identification, and the Europeans are just really damn hard about it, particularly the French. And so whether or not something is truly anonymous is very different outside of the United States, and therefore you have to go back to them for that secondary consent when that new usage comes up, which makes it almost virtually impossible to use the data for a future study that we haven't even thought of what the value of that data might be down the road. So that's something that, to me, that's on a daily basis the largest impediment for us in truly making the individualized data helpful because of the international privacy laws. And even across the United States, the different privacy laws across the individual states have varying standards. And until we get sort of a unified privacy standard that we can work to, it makes it very, very difficult to share the data in much more than small chunks.
Eris, do you want to jump in on this at all? Oh, he pointed the finger. I have to jump in. So I was thinking the following, and Larry used the term consumerism, right? So what's more important to us? The knowledge that is in a drop of blood from my finger, your finger, or my behavior with my credit card, my score, where I go, where I hang out, what I read, what I buy, what I wear. So in society, we have two completely different interpretations of how my consumer life is dealt with and what's the content of my blood. Isn't that funny? Because it leads to this sort of dual nature of how we're fighting over this. Apparently, other than our credit score and our bank statement, we're quite okay for everybody to know what we visited on the internet, well, with some exceptions, what we buy, what we wear, and so on. It's visible. We're quite okay. Apparently, that's pretty personal, but we're okay. But what's in our blood, we go up in arms. But what is actually more defining of us? What's in our blood or how we express that as people and as consumers? And I realize that that's a profoundly philosophical point, but it's actually leading to this debate. So that's point number one. Are we actually asking the right question? Because we've answered it in one domain, and we're maybe slightly hypocritical about another domain, right? That's for everybody's individual choice to make. The other one is that it's absolute human nature to want more. So all of this with DNA and omics and everything that we do and everything that everybody else is doing, oh my God, it's the latest shiny toy, I want it now. Excellent. So here's a little bit of a reality check. In the public domain, there is what? $3 trillion represented of biomedical research to date. Think of it simply, one metric, all the papers in PubMed. Just one metric, representing for the last 50 years, $3 trillion of value. And each of those started with an experiment that started essentially with a drop of blood from somewhere, human or otherwise. So we're really messing around with adding a decimal point to $3 trillion of research. And I would advocate that one of the things that we don't spend enough time with and on is actually restudying what we've spent so much money, and because it's 2 months old, it's now old. I don't like that.
So, speaking of studies and inventions, another legal overlay is patent protection. And the Supreme Court has been active in this area with 2 cases. And Dave, I'll start with you. One of them involved a company that did not exactly get a good name for itself, Myriad. They got the patent protection on, I mentioned before, breast cancer gene, and they took the view that that invention, identifying the gene, was protectable, and they refused to license it to anybody pretty much without a fee. And in another case, which I'd argue is more consequential, involving Mayo, I don't know if Steve Ender is still here, but Steve actually was the one who brought that case, so people don't like the case, you can find Steve later. It involved whether or not a treatment, in this case it was how a drug was administered in a particular context and its impact was measured, was patentable. When you put those 2 cases together, it's a pretty profound impact, both in terms of what level of protection you have for identifying genetic information or protein-based information, and what therapies you might use in conjunction with scientific knowledge. So, David, you are in this patent world. What is your view of the nature and impact of the Myriad and Mayo cases in terms of research in this area and its impact on development of new technologies?
So, one of the principles that we take away from the combination of those 2 cases, at least in terms of research into genetics and particularly with respect to precision medicine, is that the identification of what would otherwise be a law of nature, the arrangement of parts of our human structure, is itself not eligible as patentable subject matter. Now, the Supreme Court also went a little further to say that the identification, the process that we have in place to identify a law or something that's physically occurring or naturally occurring in nature, is again questionably and probably in most cases not patent eligible. So, as patent attorneys, that narrows maybe the window of processes that we might look at that might gain some sort of patent eligibility. By patent eligibility, I mean, can you apply for a patent? And it focuses us maybe on, instead of the identification of a certain configuration of DNA, rather to the treatment or the therapeutic aspects that might be different and might not be something that's flows or stems from the natural occurrence of that gene sequence even. The troubling part is that we've also had another couple of cases, several cases actually, that have built on top of those 2 cases in recent years that also influence the patentability of the patent eligibility of other ideas that I think are also quite related to this area, which is whether software is also patentable. And those I think have I believe they actually have probably a greater influence in this field than will the Myriad and Mayo cases, simply because it basically raises a significant bar to patent eligibility for inventions that are expressed in software. And I think really, from my perspective in this field, many of the hurdles right now are computational. We're trying to figure out ways of reducing cost at a computational level that probably would have the greatest impact with software fixes. Software being a way of hopefully overcoming the limits that we have in hardware. Over time, we'll see hardware catch up, but we'd have maybe a greater potential of a faster solution in software. And so, there's a concern at least that, to the extent that we can, develop new ways of solving big problems more efficiently. We may not be able to protect that sort of invention. I'll play devil's advocate, though. There are many fields, and one of those is also, I think the mobile phone industry. You're familiar with it, where there's been a lot of innovation that has been opened, and where people, even who, companies who have patents, have opened up the patent portfolios for innovators and entrepreneurs to make use of them. It could be limited use, it could be free use of the patented inventions. That may be necessary in this sort of space as well, so that even if you are not eligible to get a patent, maybe you publish on it, maybe if you are eligible to get the patent, you at least dedicate it or open it in some limited form for the public. So I think that the impact of Myriad, it influences what is patentable. Does it influence the development of the field? I'm not so sure it does as much as maybe some of the other case law relating to software.
The facts were very bad in Myriad because they were refusing to license to anybody, without paying a substantial fee, and that included researchers, and they charged too much. In some industries, they've come up with licensing regimes that enable innovation to go on top of inventions. The fact that Myriad was acting the way they were may have influenced how the courts looked at this. Larry, you're obviously a seasoned inventor. How do you look at this landscape?
It's funny because we talked about this at lunch today also. I don't see patents quite the way I used to, because I have written 600 of them that have been approved by somebody, mostly in small states.
Your name is on 600 patents?
Yeah. Isn't that funny? Anyway, that's what happens if you don't have anything better to do. I don't know. And the way I think of patents actually is back to your idea about innovators trying to do things, which is that if you're trying to raise money from either venture capitalists or from Qualcomm or from other strategic partners, if you have not a hope of protecting what you're asking them to spend hundreds of millions of dollars on, you can't get it. So you're done. So in a funny way, I see patents not as keeping things out of the hands of your competitors in the market, but for letting you get started in a funny way. So I've raised a lot of money, and it's always been around things that were patentable, and those patents have all held up so far. But I mean, this stuff. I mean, I was just writing down what I think the two rules are, I think, for being patentable. One is not obvious to one skilled in the art, and the other is that the patent has to fully enable someone, after they read the patent, to do it. That's it.
Although that second one is the one that software patents have gotten tripped up on, and part of this problem is that software patents, you didn't usually give the code, so you wouldn't give people enough information to enable it. In other contexts, you would have this enablement requirement as a meaningful one. Part of the challenge has been getting the patent system to fit with software. That's been an uneasy effort over the last 25 years, and David's right, there's been a recent case that's had a big impact cutting back on software patents. Carm, what's your take on the impact of intellectual property here?
Yeah, I mean, I can give the software perspective because that's kind of where we're at. I mean, I think, the patents, so if you look at existing other industries, right, non-healthcare, right, and how software's kind of lived and especially around algorithms, and I think that's really where this comes down to, is the computational pieces, and that's what's going to, from a software perspective, that's what we're after. And, I think, from a business and value perspective, there will be, and there are some, emerging algorithms that are very capable of improving care, and I think predictive-based, machine learning-based approaches will really start to dominate the day and take over a lot of stuff. There's a good news and a bad news for companies in the space. The good news is that you can get patents around those things. The hard part is they traditionally they haven't stood up very well, because if you sort of change one rule in the algorithm, you can get away with, hey, this is different, right? And so we'll see how that plays out. So, our perspective on this is that it's good to still have that capability, because from a business and value perspective, there's companies that are going to they have to build a business around that IP and bring it to market and create successful companies around it. And I think the patent process will help in that way. I think in the same breath, these algorithms, it's yet to be determined, how defensible that position will be from a software perspective, and from a legal perspective. I think there hasn't been. I haven't seen anything really strong saying, hey, we figured out this to treat this disease in this algorithm, and nobody else can touch it, and we own the domain. And I think the variability in algorithms will really create an environment where you'll have all these, I see a future in 5 or 10 years where there's just, hundreds of algorithms running around helping you decipher and interpret results and guiding doctors around treatment courses. And we hope to be a part of that around prescribing drugs. And so,
would you rather be in an environment where those algorithms were patentable, or would you rather be in an environment where there were no patents?
Well, and that was kind of my last point, which is like, if you've seen other industries, a lot of this stuff has just gone open source. Right. And I hope we head down that same path here, because the benefit, the benefit to patients, the benefit to all of us is going to be huge. It's just a question of, are those people publishing those patents or publishing those algorithms going to be able to recoup enough value from that to make the equation work, and people aren't going to get all protective around it. And we think about that a lot. I mean, in our world in prescription decision support, we see, we look at a lot of studies that show, they're public data that show, wow, if you do X, Y, and Z, you'll improve care by so much, and that's a validated study. And so there's sort of that history there around existing publications, and my hope is that we head down that way, and I think open is way better here than sort of walls around all these algorithms and new computational things we'll figure out in the next decade.
So, Eric, I'm going to go to you. Go ahead and comment, and I'll ask you another question. Go ahead.
I think I look at algorithms as tools, and let's start with trying to trace the money. So and you asked that, you started that line, which fence would you rather be on? Would you rather be on the side of the ground penetrating radar, or on the diamond found by the ground penetrating radar? Which one would you like? I know which one I would like. So the algorithm is like the device that will help you see something somewhere, but the most amount of return is at the other end of this. And one of the arguments that the Patent Office is making about the algorithms is that an algorithm that you use, a computer algorithm that you use to find something, rendered what you found obvious because the algorithm found it. And therefore it was obvious, and therefore it fails the test of non-obviousness. Well, that's the same. That test from the Patent Office is failing in the rebuttals, because it's the same as saying that I was looking down the microscope tube and I saw what led to the invention. So the modern day computer algorithm is the equivalent of the microscope tube of a few years ago. So when common sense circles back into all of this, we realize that the money is not in the microscope. The money is in what you saw, and were you smart enough to make something out of this. And that's why the Myriad case taught us that 10, 20 years ago, it was okay to mess around with the idea of the gene and the value of the gene. But today, the value is what you make with that information that has nothing to do with the algorithm that you used. But having an algorithm is absolutely a competitive advantage, like having a ground-penetrating data. So you'd better have damn good algorithms, but don't expect to make money from the algorithm.
Now, I want to get to the final point and let Melody start off with is the data infrastructure, you mentioned this before, to support terabytes of data about people is going to be a necessary prerequisite for this revolution to happen. How close are we to building that infrastructure? You've already mentioned the privacy rules being a part of the challenge, and how do you see that developing? Where is that infrastructure going to lie? Is it going to be in the cloud? How's it going to be accessed? How long before we get it?
I think we're quite a long way into that, frankly. We are seeing that our usual cloud providers like Amazon, like Microsoft, Azure, they're already there. They're already doing it, and cloud is absolutely how it's going to work. Now, there are certainly So to me, the challenge is in the infrastructure of either the collection of the storage of the data, that's already there. To me, the challenge is in the sharing and making use of the data. And that infrastructure, I mean, the technical pipes are there, the ability to move the data is there. The ethical, moral, and legal infrastructure is not yet there for us to figure out how we can share that data in a meaningful way while still recognizing the value of human privacy. So.
And that, just to give people a preview, is actually the core of the third panel. We'll talk a lot about that issue. It's a big one. Any other comments on that point before we go to the audience?
I think I would just add, I totally agree with that. I mean, what we see in our world is a lot of this whole unstructured data problem that we're in front of. Brett from Intermountain was talking about this, is sort of the NLP, processing all this data and making sense of it, especially in healthcare, because you have this just massive amounts. That's going to be massive amounts of unstructured data that we have to make sense of. A lot of documents and PDFs.
Back to algorithms.
Yeah, and that's where it will evolve. But I think, that's where it's going to have to. I think that's where we are right today. If you say there's plenty of infrastructure, it's the question of interpreting and making that useful and dealing with the privacy around that. That's sort of the state of affairs today.
Yeah, I mean, the data is there. The collection of the data is there. There's so much data that falls to the floor today that we have it. We just don't know what to do with it. And so it is making meaning of what we've already got. And there's a lot of work yet to be done around that piece.
Quick shout. I think I saw Jana Watson-Capps here from the BioFrontiers Initiative. The theme coming across here about algorithms and data analytics around bioscience and healthcare is pretty powerful. So that's going to require a lot of collaboration between developers, software developers, and scientists and doctors. And they're going to need good lawyers to help architect these systems and maybe figure out the IP issues as well. All right, let's go to the audience, get people's thoughts, questions on precision medicine. And we usually ask a student to take the first question. I know there's both law students and medical students here, and I'm not afraid to call in people.
How's it going?
Oh, come on. I'll extend it to alums. All right, great. Yes.
So you talked about some of the willingness to share your personal information, so the information that's in a drop of your blood versus where you've checked in on Yelp or on Facebook, things like that. Is there some psychology that goes into that? So the idea of multiple levels of privacy preventing you from sharing maybe what's in your blood versus the ease of sharing the information about where you've been recently. Do you think that that plays a role into some of the reluctance that goes into sharing that information?
Yeah, what a brilliant question. And I don't know, maybe. I know that it was a great question, but I sure as hell don't know the answer to that, but maybe some thoughts. So what makes us think that when our drop of blood is analyzed and then entered into an EHR EMR, it's not electronically available to the same degree? It's now sitting behind certain firewalls, as is our credit card behavior. But that doesn't make it any difference. It's how we think of it that is changing the narrative of the data set and the use of the data set. So our credit card information, just to use that example, is amortized and broken down every which way to Sunday, and that's why we have what we have in our society, for good or bad.
So a couple things on this. And first, Karen, have you got your summer job yet, by the way? All right, so there's a tech-savvy, super smart lawyer there. Anyone here looking for one or a summer intern? Talk to Karen. She's a rock star. I think the answer might be, let me test this out, that people don't trust that the data will remain cabined and walled off from other people who they don't want to get it. So whether it's a family member, whether it's an insurance company, whether it's an employer, I'm guessing there's a skepticism that the data would remain with the trusted set of people who are authorized. And if you don't trust that it will remain in that group, you can understand why people would be like, hey, maybe I don't want my partner knowing about X, or I don't want my employer knowing about Y.
Well, absolutely. It's that fear. But all I'm saying is that it's an identical fear as it should be. So I don't want my partner or employer to know that I really spend a ton of time on Amazon buying X, Y, Z versus this is what it is in my drop of blood. What's the difference? That's all I'm asking. What is driving more of that fear?
Can I?
Yeah, please.
Those of you who read in the New York Times last weekend, I think it was, this remarkable article from a guy who, as a gift, not only did his DNA, but he had his parents do their DNA also. And then one day he gets a little note. He wrote this article. He gets a note from 23andMe. Hey, we found your grandfather. Would you like to meet your grandfather? And it turns out that after he met his grandfather, it turns out his grandfather was the illegitimate son of his father. And his parents got divorced, and it was this extraordinary article. This just happens. And so, you read that article?
No, I didn't. But
it's a remarkable article. So there's all kinds of craziness that's going to come out of this. Just saying.
all right, we've got a few people with their hands up. Who's first?
As one former student of Phil, I was afraid he was going to call me, so I had come up with a question before he said that. And this is for Dr. Paradis, who's sitting next to Dave. I think the difference between the fears is that, on the one hand, the shopping predilections of us can be changed by us. We make the choice to purchase what we purchase, and our credit record can be repaired by choices that we make, whereas the drop of blood, there's nothing we can do about that. And so I myself have a much bigger fear of a potential employer, for example, knowing that I am forever incapable of overcoming my autoimmune disease, which I am, versus changing my spending habits. So I would like to get your thoughts on that.
So you just said that what's in your drop of blood is fundamentally immutable. And I'll just direct that to the Nobel Prize winner called Larry Gold, who will debate you to the end of the earth, and so will I. Because if I go and I consume 52 burgers between now and Sunday, what's in my drop of blood will show up as an immense risk factor to whatever employer, should that information become available. So you have, in the previous panel, made that clear with all sorts of data, and you know this, and everybody here knows this, and so I'm stating the obvious in response to your comment. Yes, there are immutable things in your blood. Yes, there are immutable things in who you are and how you spend your money. That's also been proven again and again and again. I think the key point, which has to do with, can we improve the outcome of the life or death question that Larry posed very eloquently, and our fear of data that may help that for us or other generations are today incompatible, and they should not be. But the immutability of what's in your blood, no, sir.
Other questions?
So what could happen to this equation if in fact, our healthcare system was not driven by employer-based insurance or insurance companies?
Well, this is great because we have a natural experiment, and I think Larry averted to this. When you look around countries around the world, is the fragmented nature of our employer-based system going to accelerate or hold us back in adopting the potential of precision medicine? Larry, you want to take that one first?
No, I mean, I think that we're having a social discussion, which I don't have anything to say about it. I think that if you remember, there were times that we all thought the commons meant something. That's really what we're talking about, is the commons. When will people kind of get over it in the interest of helping both themselves and their children and their siblings, as well as other people? And that's like an un-American question. I don't get it, okay? I just think, and it is a social problem, and I think this battle will be fought on social elements, not medical elements. I think that we will show we ourselves will show in Oxford in the next couple of years tremendous benefits for people who die of things like heart disease and various other things. And we in the United States will slowly adopt something that was invented here. It should make us, it should drive us crazy, in my.
So there's a few points here. One is the health insurance system we have here compared to other countries. Second, there's the social attitudes, more libertarian versus communitarian. And third, there's the collective action issue, which is that data infrastructure piece. Will we have that in place in a way? Anish talked earlier about these interoperability challenges. That will come up here too. If you don't have that infrastructure, other countries are able to, for better or worse, move more quickly. I think we've got someone who wants to jump in on this point here.
Before you go to that,
yeah.
Is there an objective difference between companies and self-insured companies, both of their employees?
So in that, within the U.S., you may see natural experiments. So a self-insured company or a system like an Intermountain Health may be more able to drive adoption of this. People care to comment? Have you seen different types of plans or employers being more proactive in adopting new technologies?
Absolutely, absolutely. I would say that we're seeing the employers who are more on the self-insured side are being more innovative around how they're doing it and what types of wellness programs they're rolling out, fitness trackers, and data collection that they're getting back from their employees. And their employees, there is a common sort of thing within an employer group. But our experience is we're seeing more infrastructure adoption, more innovation, more change within the United States healthcare system than we are seeing globally. And it's frankly just a matter of funding. The international healthcare space doesn't have a lot of dollars for innovation around remote patient monitoring or new algorithm studies or things that we're seeing so much up here in the United States. So I don't see that the insurance system here is slowing us down. I see that we're actually doing more innovation on a global basis.
Yeah, I think the interesting part here in the States is, right, we have, there's all these experiments going on right now. And so, the question is which one of those experiments is going to work in terms of doing value. And there's plenty of self-insured companies that are doing really innovative things. Boeing, set up their own ACO, and you've got, and then you have systems like Intermountain that are incredibly far down the road. My thesis is that the health systems, especially those carrying risk and aggressively pursuing it, are the ones that are going to break through because they have the marriage of, phenomenal clinical care with a plan, kind of holding that together, and that's, everybody, some people say, oh, follow Kaiser, right, because they've got that innovative model, but I also think, the Intermountains of the world will push us there. And I think, the U.S. has a tremendous opportunity. I think the underlying risk is that in other countries, in Europe, for instance, you've got these unified platforms in place, unified health systems, right, where the government's controlling a lot of it. That gives them a potential tremendous leg up to do, instrumental things to gather all the data necessary to do some of these bigger experiments. And that may or may not exist here in the United States. It's a question of how we'll come together and fit the pieces and how open we'll be and how much we'll share in all this stuff at a grand scale at a federal level. So it's still being sorted out, I think, in many ways.
Well, to take the Qualcomm example, when Europe, for example, gets it right behind a standard like GSM, they can catalyze movement in that direction. But when they get it wrong, like GSM, they end up suffering because CDMA, which turned out to be better technology, only can emerge where you allow for experiments. And so the U.S. system, which is more fragmented, has more experiments, ultimately that can produce some really interesting, innovative results, but it can't necessarily move as quickly and in unity as you can see in other parts of the world. So it's a different type of bet. That brings us to the end of a really wonderful discussion. Let me thank the panel for a great discussion. Welcome people for joining us in the reception for our final panel. You were delightful. Really. Isn't he wonderful? Can you join us for dinner tonight? Are you free?
I might be. I'm a little jet lagged. That's my only concern.
Well, you can bail anytime you need to.
So I'm going to
You're
see
welcome.
how long.
See how you can last.
Mr.
You guys know
Allen!
that's right.
Time. How are you?
Yeah, they work together with Bill.
How funny to see you. I was just talking to Ginny Orndorff, and I'm like, I'm so kind of different aspects of my life. And here we are, all in healthcare. Well, you were in it before I was, for sure. How are you? I'm good.
I don't have any. Absolutely. You sat next to Larry, and
And I sat next to him.
you only dropped 2 swear words in an hour, which is like in a new record.
I dropped one. Damn. He dropped the F-bomb. He hit the F-bomb. How are you liking it out here?
Are you based here?
No, I mean, there's so much stuff I want to do with you guys. I want to change the world. Yeah.
I'm traveling all over now, so we've got offices in Paris. It's a weird, great. I'm trying to get Carrie this summer. Personally, I'm trying to get her for us this summer.
It's great to see.
How do you like this? You enjoying it? It's been a while, right? 3-ish, 4 years? Yeah.
When I had both campuses built in.
Yeah.
Well, it wasn't so much the law.
No, thank you. That was great.
And I moved out here, I was not quite a year. No, no.
Hey, Larry.
When Don Elliman asks me to do anything, I do
I don't know, I'm tired.
Oh, Don, sure. How's her family? Good. She's great. She's a Kenyan freshman. She's doing great. She's trying to get on the 5280 for the summer. And then Evan and Ben. She wants to be a writer. And magazine would be.
Conference recording has started.
But Evan and Ben are on a college trip now, trying to figure out where he's going to go. So, yeah.
We leave one for every moderator. So that's great.
We get along so. I just turned 50. And he was there and posted some pictures on Facebook, and the one that got the most likes was the picture of me.
We'll bring the technology.
I know. It's great to see you. Excuse me. I'm giving you a card.
I just got introduced to Jim Malt.
Oh my God! You meant to.
You must have been so
Captain Wizard Boss.
One of my partners had
Oh,
Wait, you only did it once.
She lives here too.
Yeah, he lives very close. He lives up in Everett.
Yeah.
I live there too.
Oh yeah.
Yes, I did say.
Yeah. He is.
We already talked to my husband. Yeah, he told you I have metastatic breast cancer to my liver covered and all that. So I am, you know, I was curious because I'm sending out my tissue to Foundation One, but it doesn't sound like anybody knows anything when it comes to
If I was in your situation, I would do that too. I would
Jim.
decide what to do with that.
And by the way, I did the Octotype thing when I first had it. I'm one of the unfortunate 2% that had a relapse based on everything.
And he knows something about everything. Just ask him about some highways. Not so much just so
Go ahead and get some information. Actually, the Octotype didn't work. Yeah, I'm using Rocky Mountain Cancer.
Well, I
but
enjoyed
to get a consultation as well. Rocky Mountain Cancer.
Yeah, thank you.
I've been to a bunch of doctors. I was in California. I was impressed by and I was last year. So how do I know what to do with that info?
Thank you. Yeah, we'll take that home and do it. Yeah, you know. Put that on my wall.
Right. I can post it right in home cancer. We have a guy who's working on the CFO of a company where they basically, they don't attack the first incidence of lung cancer. They take it 2 to 3 times and have the remedy for that. Remedy, the treatment for that. Lung cancer is, like City of Hope told us, it's the craziest cancer. I can't you take so readily.
I've had to step off. I'm missing.
So you wouldn't know either for this, and you didn't know the afternoon afterwards. It's like, hello.
But I can't manage it. So I'm missing that. That has.
You don't have to say anything. I just wanted to ask you. The other thing I wanted to tell you was I've gone to every app under the sun for Android and Apple, right? And I'm trying to find an app to like my symptoms, put in my fear, put in my mood. I'm just sitting in Berkeley, my dad. I know. I tried actually the ADHD app, which came closest. When you go to use these apps, they are great. They don't work for patients like
I don't know whether they got a big user but when they have a user essentially they create look at each other, look at each other's profession. They've done tremendous things for
Sure. You know, I have to limit the number, but Qualcomm definitely has.
I will look. That's all I wanted was a way for my doctor to see my symptomology rather than bring in scraps of paper. And even on Navigator.
Yeah, definitely. I'm
Like,
always
really, I'm
looking
going to
at
develop one. This is stupid. Okay.
This one, for example.
Yeah, I'll try it. Thank you. Thank you.
I would love that. You are going to dinner? Okay, you're hilarious. So I may need to go to dinner just to sit with you.
That's a great hat on.
It's awesome.
Fabulous. My favorite restaurant.
How are you doing? How are you?
So I also wanted to mention, I'm trying to put together a session and I thought it'd be
Actually, FDA also is one cybersecurity guidelines for all medical schools. Yeah, it's got some, there's a lot.
Yeah, so can we chat at some point if you have some time? I would love to. Yes. Thank you.
Yeah, it is fabulous. It is fabulous.
I used to live in I actually lived in
Yeah, it's lovely.
Great to meet you.
Nice meeting you too. How are you? Did you hear from my people? I did hear from them. Good.
Yes, I'm Annie. How are you? Yes. Yes. Nice to meet you. It should be fine. I think it's, it always has a
Hi, how are you? Glad to see you. Nice to meet you. Nice to meet you. It should be really quick.
We get water about that.
And kudos to Dean Weiser and his team for putting on, as always, an excellent, provocative conference today. Makes me proud of my alma mater, CU Law. I'm Annie Harrington. I'm a senior associate at the law firm Squire Patton Boggs in town. Some of my clients are actually in the audience today, which is fun to see. I spend a lot of time in my day-to-day practice thinking about protecting the balance between patients' privacy rights versus how to expand access to important healthcare information. So I'm particularly thrilled to be moderating a panel on that topic. And I'm particularly pleased to be moderating a panel comprised of such an impressive group of folks. I'd like to briefly introduce them before diving into our questions. And again, we are going to broadly discuss the small topic of creating a framework for shared access to healthcare information. So to my left, Elizabeth Coker is the Chief Operating Officer of 3P Health, which is a Boulder-based healthcare delivery company, digital healthcare delivery company, offering software platform designed to assist healthcare industry organizations in engaging their patients, providers, and subscribers via a personalized mobile interface app. We'll look forward to hearing more about that. Sharon Gillette is coming to us today as the Principal Networking Policy Strategist, it's a mouthful, at Microsoft Research. She focuses on issues such as net neutrality, cybersecurity, universal internet access, all very relevant. Next in line, Sally Hatcher. She's a self-described serial entrepreneur, president and CEO of Kindara, which is a startup that began with the launch of a very interesting fertility tracking app. And finally, Dr. C.T. Lin has a big job here at Anschutz. He is the Chief Medical Information Officer for the University of Colorado's campus. So thanks to all of you for being here. So I think I'd like to kick us off with a bit of a level set. We've talked a lot today about, and we've bandied about the term healthcare information, but I'd like to have a level set discussion about what that means. So clearly, healthcare information includes what we routinely think, medical tests, imaging files, lab reports. But let's talk about how far that definition should extend and how do we protect against casting too wide a net in how we define healthcare information. Liz, I know this is an area that you grapple with every day. So can you kick us off on that discussion?
Yeah, I mean, one of the things that we have found with
digital health in particular is that just like in general consumer privacy, you need to put things in context. Let's just say my fitness data, if I'm doing Map My Ride, something like that, is socially available to the world. I pretty much have given my consent for it to be that when I sign up for the app. But if now I'm using that same fitness data to help me manage my diabetes or post-operative PT, then it's a completely different context. And so one of the key issues that I think needs to be addressed when it comes to the definition of health data is the context of how that data is going to be used. So it's not just about providing permission, it's about providing permission in context. And one of the other panels talked about this is how do you give multiple permissions for different uses. And finding a way to make that simpler is going to be really important because HIPAA really doesn't provide enough, at this point in time, doesn't provide enough detail when it comes to how it's to be used, basically because HIPAA was put in place well before all of this data and the digital health phenomena came about.
Thank you. Others, thoughts?
Talking to me?
Yeah, sure. CTA, looking at you. Looking at you. Go for it.
You know, most of my world in the health information management at the University of Colorado Health is around the electronic health record. So its pure definition for me is any data entered by the healthcare providers on this campus, on the 5 hospitals and the 400 practices that are part of our healthcare organization entering data into our EHR. So that's vital signs, diagnoses, medications, lab results, and so forth. And I think that's a fairly concise description of health information. What gets fuzzy is what's slightly outside of that. Is it the personal health record? Is it patients' comments to us about themselves? The concerns that they express, is that mineable for useful information? When patients suggest that, I think I have diabetes, so can you put that on my list? Or, I don't think I have gout anymore, can you take that off my list? And then you get into all sorts of indignancies from the physician saying, how dare you tell me my job? I know whether you have this or that or the other thing. But honestly, most patients know when the last antibiotic prescription was 3 years ago, and can you please finally take that off my medication list? And so having patients participate in their own care and adjudication of what's accurate, I think is important. Where I think it gets very vague is, and I'll just launch into taking a slight left turn here with definitions, is what else is useful or interesting about patient behavior that might be medically relevant? For example, there was a research study out of Stanford. I don't know if anyone had read the Google Stanford research study on drug interactions using the Google plug-in for a web browser. I think it was either Google or Bing. Maybe it was Bing. So there's a module you can plug into a browser where Bing or Google, one of the two, can track from a specific IP address what things you search for. And what the Stanford researchers were able to take from this data were specific IP addresses, we don't know who they are, who would search for symptoms of hyperglycemia, high blood sugar. So I'm peeing a lot, I'm sweating a lot, I'm hungry all the time, I drink a lot of liquids, I don't know why. And so aggregating those symptoms into a presumptive diagnosis of perhaps hyperglycemia or diabetes, and then saying from that same internet IP address, they've searched for the word pravastatin, which is actually a known association between the drug pravastatin for cholesterol lowering and the incidence of increased blood sugar. Well, that's known. Okay, so that's your checkpoint. Now, what incidents, and so they actually mined that data to see what other things these individuals or these people or these computer sites searched for, and it turns out paroxetine, which is an antidepressant medication, was also part of this search pattern from these individual IP addresses, and now they hypothesized that maybe there's a drug interaction between paroxetine and pravastatin that may cause multiplicatively hyperglycemia. Now you've got big data worldwide pointing to a brand new association that's not in the medical literature. And they actually were able to prove it later, that actually, you back your way using big data into this sort of thing. Now, is that discoverable? Do we go after those IP addresses and say, who are you and which healthcare provider are you? And you have hyperglycemia and I need to go intervene with you. Where does that definition stop? And I think that gets very gray.
And thank you for publicizing Ryan White's study from Microsoft Research, actually. By the way, all that data is anonymized when our researchers work with it. I'm not even sure they know the IP address because that's actually an identifier. I think they just know it's the same location. There's a lot you can do based on, there's been actually, in addition to that, there have been a lot of other new provocative hypotheses coming out of looking at search logs, but you don't even have to go to search logs. People post stuff on social media, people tweet stuff on Twitter, and you can actually, out in public, and you can actually derive a lot of really interesting medical hypotheses from that data. So now, did people give their consent to have that studied? I mean, the whole framework that we have is completely not linked to this new world of there's all these different forms of data out there, many of which people have just put out there on their own volition. But that is why I would argue that we need to be thinking more about a framework of how my data gets used. Is it going to be used to help me or to hurt me? I know there's a fair number of lawyers in the room. I think if we want to incentivize data sharing in health in a healthy way, that we need to be each individual sure that the people who have access to that data have our backs. They're going to use it to help us. I think New York Times articles have gotten a lot of play today, so I'll add another one. There's an editorial this weekend in the Times, the Sunday Times, arguing that discriminatory uses of data particularly from fitness trackers, could be very, very, very problematic, and that people should be assured, for example, that their employers aren't discriminating against them based on how often they exercise. Interestingly, the paper, the editorial referenced an article which I know the authors of it because they're also at Microsoft Research, but they didn't know that they were going to be referenced. But it's several law professors who proposed various legal frameworks that have to do with preventing discrimination based on the use of your data. I think that has to kind of complement, any use-based framework really has to complement what we have today, not change. We still need the protections we have today. It's kind of like the analogy would be between, we have HIPAA today, but we still have IRBs, right? They serve different functions, right? HIPAA says, other people can't look at your data. The IRB says you can't do something unethical with the data. That's kind of the use-based framework we have today. It feels like with all this new types of data, it's not necessarily an academic study, but what is the equivalent of that kind of, prevention of harm?
I think you also see there's such a distinction between the medical establishment and HIPAA as we think of it, and the internet world of apps, which is, it just truly is the Wild West. And what I find so fascinating is the things that we try to protect so carefully under HIPAA, people give away very freely on the internet. So my example is the company that I'm with is Kindara. It is a women's fertility company. So you track your cycle, and if you want to get pregnant or you don't want to get pregnant, or you just want to track your hormones, you use this app, and you use it every single day to track your cycle. So these women are extremely active on this. And we've had million-plus downloads with several 100,000 very active users. And not only do they put in their personal data, but they are given the choice if they would like to publish their data to a community of users who can then provide them feedback. So Kindara is not selling this data. We are not using this data. We do not give out this data. We have nothing to do with this data, but within the community, people are publishing very personal information and asking internet colleagues for their opinion on their personal data.
And it's identifiable? It's published with their name or their...
If they write a name for themselves, so they can choose to call themselves whatever they want, and then they are identifiable by, if I name myself Suzette Crepe, then they know me as Suzette Crepe.
Interesting. So I think that is a very nice segue into sort of some questions having to do with barriers to expanding access to healthcare information. There is a lot in the literature that suggests that patients themselves are the greatest barrier to expanding healthcare information, or at least to the free flow of healthcare data. That it is patients' reticence to allow their data to flow outside of their immediate control that is, in fact, sort of hampering access or the creation of a easier data flow system. Is that is that how you? I mean, obviously, your example runs completely counter to that. So let's talk about.
Okay, so yeah, I mean, it's so interesting that again within the medical system and within HIPAA, your drop of blood that can disclose your autoimmune disease, you do not want that disclosed, which is where I tend to fall. However, in the internet world, there is already so much data available, and people are tracking so many things. And within a very short period of time, you'll be able to use sensors and patches to track so many of your hormones. There are now mail-in services. You can have all of this information about yourself pretty readily available. And so what I see is the exact opposite of people with now a tremendous amount of data that's far more personal than your Fitbit, the number of steps. You know, you can know your TSH, you can know your thyroid stimulating hormone, you can know these pieces of data, and you now can take them to your doctor. And your doctor has an all new problem on their hands that the patient walks in, and it's not just one patient, it's a patient with a ream of data where they've gone to other services or tracked themselves and say, you know, look at, I'm presenting with all these symptoms. I haven't just gone to Dr. Google and, decided that I have a rare disease. I'm presenting you with all these facts and information, and you now need to deal with those. And I think that presents a real problem that is, the doctor has to deal with that at this point. I think it's a liability issue, and there's this huge problem of sorting through all the data, what's relevant, what's not, where do I start with a diagnosis, how do I deal with these medical records that are not within the EHR, but my hospital has not caught up with the hundreds of apps that these people now have available to them that are collecting this data.
Absolutely. So CT or Sharon, do you have any thoughts about how doctors for you CTs, how doctors here at Anschutz are advising them to respond when patients come in with either their own PHRs or with their own reams of information about their conditions? How do you advise your physicians here to deal with and analyze that information? Or do you?
So how many hours do you have?
Yeah.
I have lots of thoughts about this, and I have to, in fairness, reflect the fact that as with any population of humans, doctors are a bell curve of technology adoption. From the, how come I don't have my natural language built into my speech recognition Bluetooth built into your darn EHR CT, you're decades behind, to the, you will pry my pen and paper out of my cold, dead hands before you force me to use your darn thing. Now, I have to acknowledge that among physicians using EHRs, and I know there are not many physicians in the audience, but a daily occurrence for me is the fact that I have a large target painted on my back, and I like to joke that I'm the best loved physician on campus because of my forcing folks to use the electronic health record system. The challenge is that we know that physicians are burned out. There's a national epidemic of physician burnout, and not a small fraction of that is personalized in my walking around and people pointing at me, that's the guy, he did this to us. And so I feel that quite acutely. And we know that physicians being turned into data collection clerks, and especially those clinicians who during middle school never took the typing class because it was for the secretaries, are now completely feeling the pain of saying, how do I interact with this new world? Because they're digital immigrants, they're not digital natives. And that's been a huge concern for us. Now that's just to lay the groundwork for the question that you asked, which is, well now the patient brings in No, better than the old days before, everyone is wired. They would bring in an inch, a stack, a foot-tall set of printouts from the 17 other hospitals and 40 other clinics that they've been to nationally. And my Mayo report is here, and my Cleveland Clinic report is here. Can you please read through that in the next, 15 minutes and tell me really, I came to you because I know you'll have finally the answer for me. It's an impossible task. And now that's been magnified by the internet, where patients can now send, and this is my colleague's number one fear, you're going to give them email access to me? You mean after they watch House on Thursday night, they'll have 15 questions about, I think I have that disease. And you think I'm going to be able to get any of my regular work done? No. And they're going to say things like, I was searching on Alzheimer's that you mentioned last time, and can you please read this following 75 websites that I found on Joe Bob's Alzheimer's site and tell me what you think? And I can't possibly, they say to me, do my work because you've opened up this floodgate of questions and demand that I couldn't possibly satisfy. So these are the types of, and much less, here's my Fitbit data on a daily basis. Can you ping me and tell me what you think of the 1,700 steps I took today? What are you going to do with that? So clearly we have informatics tools we need to build to aggregate knowledge in a way that's useful to both patient and physician about patient behavior and how it impacts their health. Absolutely. Are we there yet? Not by a long shot. But I'm not afraid of it. We have physicians who also say, when can we get the patient's home blood pressure? Because we know they have white coat hypertension. And every time they come in, they get a 170. And I'm getting dinged on all my hospital metrics because I'm not doing a good job. And yet I know when they go home and relax, their numbers are in the 120 range. They're normal at home. And I type that into my note, but I don't get credit on my codified data reports because patient-reported data doesn't count against the metrics, and I'm getting a bad report. I can't wait for you to allow, and by the way, we turned this on several months ago, where patients can now finally add their blood pressures, and it counts in the physician's flow sheets, and now we're finally getting sort of credit for patients doing their own reporting, valid data. So that's the kind of thing that we're struggling with, is accepting patients' data and using it in our regular care.
But you're doing it. Kudos.
We're starting to.
I mean, Liz, that's something that your company is really focusing on, right? Is sort of fusing the provider-patient relationship and making it more seamless and digital.
Right.
Talk to us a little bit about conversations you're having around these questions.
Yeah, I mean, one of the key issues is motivation, right? Everybody has a different motivation. It's why engagement levels can be so low, is trying to figure out everybody's engagement motivation is different. So if we go to kind of some of the earlier discussion and then back to this, patients like me, are people here familiar with patients like me? They get, just like Kindara gets, tons of people willing to share information. These are motivated people. They're trying to achieve a fertility goal. They're trying to figure out a complex problem. These are motivated people. They'll share. The greater good is more important because they know that's going to help them. But you can take my husband, who should lose a little weight and get his cholesterol down and things like this, and trying to figure out his motivation to do that is much more challenging. He's an introvert. He doesn't really want to share. He only goes to the doctor if he's terribly sick. And so trying to provide tools that allow people to engage at their comfort level is really important, trying to understand their motivation. Quitting smoking might be something that somebody hasn't been able to do for 60 years, and their first grandchild comes and boom, they've quit smoking. And so being able to share that information, whether it's share it with their provider, share it with a family member, a sibling who might be their healthcare advocate, those are the types of things that if you can enable some of that to happen more easily, we find that engagement levels will increase. Finding that is difficult, there's no doubt about it, but technically right now there's not a good way to share that information, and every provider is different. So not every provider, every doctor, or every nurse is going to ask the same questions to pull that out of their patients. So when you can provide tools that kind of click people, right? You put up on your refrigerator, you've got your high school reunion in 2 weeks, lose those vanity pounds, whatever it takes for you, how do you do that digitally? How can you share that with your provider so that they can help you get there as well? So motivation is key. The other thing is taking into account those very real generational differences, cultural differences, socioeconomic differences. Those are all barriers to sharing data, barriers to trust, barriers to health literacy. So again, if you can help the patient and the doctor, or the patient and their health advocate find common language around their comfort level, then you can start building trust a little bit better and get people to engage.
Sharon, did you have anything to add to that?
All right. I've just always been really interested in this concept of meaningful use. Now, I'm a former federal and state regulator, actually, so I kind of understand how regulators think, and that they're trying, in fairness, to do the right thing. But sometimes they're in a frame that is, it depends who they talk to, and they're not talking to the people like Sally, who are, doing these innovative things with, wearables or remote monitoring and so on. So, I think that that shows a little bit in terms of like meaningful uses. You talked about barriers to access in terms of how do patients access their information. I think actually meaningful use for doctors to use information is actually just as important, right? Yes. And that's what's really hard. I mean, until there's good analytics on the sort of wearables data that can sort of say to the doctor, this is when it's important, as opposed to no doctor's going to look at reams and reams of data. Data's not interesting. Insight is interesting, right? And genomic information, same thing. We talked about that a lot. People talked about that on the last panel a lot. You can go into the doctor with a list of mutations, but you don't know what to do with it, And that's the big issues, I think, is really making the information meaningful to doctors. I think one example I would give is, have any of you are any of you familiar with what Dartmouth Hitchcock Hospital has done with their system called Imagine Care? Is that at all familiar? They're building a system. It's built on Microsoft technology, but that's not the point. It's essentially a hospital that is noticing that there was actually a lot of talk on the first panel. The money's going to come out of the hospital, and they're looking at that and going, yes, in fact, our job as a hospital should be to keep people out of the hospital. So they're actually taking this novel step of, can we build a system that will keep people from using our service, which is a little bit unusual, but forward-thinking. A gentleman there mentioned the Wenberg GPS, and afterwards I asked him, who is Wenberg? And he explained to me he was at Dartmouth, and that doesn't surprise me because they've been very forward-thinking in terms of the Dartmouth Atlas and the cost of care and accountable care and so on. So they've taken it the next step, and they're actually building out the system and piloting it, and what it does is basically it segments the chronic care patients who are the most expensive. It outfits them with remote monitoring equipment, sort of like the thermometer we were talking about. And the data comes in. It doesn't go direct to the doctor. It goes into an analytics system, which then analyzes it and notices when something is amiss. Sends an alert. There's actually a monitoring center. I think it's staffed by mainly nurses. And they're watching these monitors. And if the monitor goes off and says, Mrs. Jones's blood pressure is too high, she gets a phone call. So this is what I would call an English example of English in the sense of plain English example of meaningful use, as opposed to a legal example. They've actually, in their pilot, had an example where a woman who was one of their patients was traveling out west. She was driving, and her blood pressure monitor was flagging that her blood pressure was very high. And just as she was thinking about, well, what should I do, her phone rings. I hope she had a hands-free, because she had a conversation with the nurse who said, whatever her name was, I don't know it, your blood pressure is too high. I'm going to find you an urgent care facility near where you are, and I'm going to direct you to it. And they did that, and the woman drove to the urgent care facility, got treated, taken care of, no stroke on the highway, thank goodness. And, that seems to me a really meaningful use of health data. But I would guess that it doesn't count as meaningful use in the EHR sense. But nevertheless, that's where I see the future headed. And I hope that we can make our legal frameworks catch up to where, they can enable those as opposed to getting in the way of it. So.
Well, carrying on the vein of helping our legal frameworks catch up. So there's no question, and it's something that I talk about every day with my clients is how do we create or open the flow of data between, for example, providers and patients with their PHRs? How can we enable the overlap between EHRs and PHRs in certain spaces, in certain areas? And there's really no question that our legal framework for that has been outpaced, in part because of the efforts of many of you in this room. What kinds of conversations are you having? And Sharon, I know you do a lot of policy work. CT, I don't know to what extent you're thinking about this at Anschutz, about where our federal policy should be heading with regard to interconnectivity or interoperability, as it were. HIPAA is outdated in that it is very covered entity centric and does not take into account and doesn't in fact even define in its definition of PHI many of the forms of data we've been discussing today. Are you having conversations about policies or about how to get around the fact that we've outpaced our regulatory framework?
Talking to me? Again?
Not just talking to all of you.
No. Well, I was going to wait for my colleagues to answer. I was going to take this in a slightly analogous conversation if you want to start with the legal side of it.
So, well, I'll jump in because I have a pretty strong opinion about this one. I do think explicit permissions are important.
At the patient level.
At the patient level. And that's how the data will be used. We have similar contracts with other entities or people. There's no reason why when I don't fill out my annual patient information with my doctor, that I can't say, please share my data for population health purposes. You're checking a box, you're doing your little surveys, so why aren't we including things like that, given that we know that we have that information in some of our day-to-day processes? Again, if I'm giving express permission, it's not a problem. That can be an annual update. You update your insurance, you update your sharing permissions. There are, I think, some very practical things that we can do to try to tie it into the day-to-day processes that people are using, and I actually think in some ways it's better to do it from a process perspective than a regulatory perspective because, again, I don't know how you regulate context, which I think is the biggest challenge as it relates to healthcare.
I don't have any. I think I've already said what I had to say about legal and policy, but I would just also note a study that was done at MIT by Catherine Tucker at the Sloan School there. And she studied how different privacy laws affect the likelihood that a person would take a genetic test. And she looked at 4 different frameworks across different states in the U.S. And the only one that made somebody more likely, interestingly, consent made people less likely to take the test. If you read them the 30-minute, explanation of consent, they said, I'm too confused, I don't want to do this. But if you gave them the choice that their information would not be redisclosed without their consent, and it was the control that they had over how their information was going to be used, then they were more likely to take the test. I think that was very interesting. So.
I'm intrigued simply that I totally interpreted your question differently, which was a question of how do we get all of this data to the healthcare provider. And again, from that perspective, if we've got all of this data that we need to get into a HIPAA compliant system, it strikes me that the government rarely leads with regulation or with policy. The government typically follows what the market is already doing. And to me, the point there is that there is a large economic opportunity. There's a market opportunity there for figuring out how to take all this data from apps, again, from my world to and to make it HIPAA compliant, and then to pass it through as an EHR through to the medical provider. And I can name companies that are already doing that. Yeah. So I tend to feel that once again the market will come up with solutions for how to move and share data, and then the government will react with regulation that either addresses problems in that flow or solidifies what's already been done.
And we heard a lot about that in the first panel today.
So I want to talk about 3 things. Great. One is consent from the patient. Second is, Yeah. And then the third thing is going to be about open notes and disclosure of information to the patient so that the patient can be the locus of control. The second one is fire and Anisha's comments about allowing patients to actually sort of drive that sharing behavior outside of the HIPAA framework, because now the patient has the control to do what they want with it. So in terms of the earlier conversation about opt-in versus opt-out, I think it's socially an incredibly powerful tool that we have to be, with great power comes great responsibility of saying to the patient on their annual consent form, we now have modified it for population health, and we put that under the treatment payment operations rubric, which is HIPAA. And then also that, as you may know, that we have a Colorado Health Information Exchange that we are regular contributors to, perhaps one of the larger contributors to, for the state information, and all of our electronic health record data goes to that exchange to be redistributed upon demand by other healthcare providers. And that's also baked into our consent form, rather than sort of, hey, would you like this time today? It's part of your annual consent, and that's part of our regular operations. And we found that to be very powerful, and it's worked quite well for us. Along the lines of having patients be the locus of control, I think that's a very innovative way that meaningful use stage 3 and these other regulations coming forward have allowed, the idea that using a FHIR-enabled app to be able to publish the data in a FHIR-enabled way to the patient's portal, and then the patient can take that and run with it. I suspect that many of our more ill and less online literate digital non-natives may not do much with it, but those who wish to can then say, can you imagine, I love the earlier conversation, I can go to my Walgreens app and have it connected, and then Walgreens can tell me some suggestions about how they can help me with my health care, and I like them better than I like your awful portal, and I can do something with it more interesting. So I think that's lovely. And that comports well with our previous research. How many of you have heard of the Open Notes initiative nationally? About a third of you? Great. So I like to say that I've been in this Open Notes field since a decade and a half ago, 2002. And this is a sad tale of woe for my lack of understanding for the socio-political complexity of a large organization. Because as a researcher in 2002, my internal medicine colleague and I had this great idea, funded with the Commonwealth grant for $250,000, to study 100 patients in the cardiology practice here on this campus and give them access. Our idea was, why not have patients have immediate access to everything in their electronic health record? Their problem list, their medications, their allergies, but also every test result in real time. The instant it's available to the doctor, it's available to the patient. Every radiology report in real time. Every biopsy report in real time. And as you might imagine, when we proposed this to the 7 physicians in that practice, there's a bell curve of responses to that proposal, right? And so you have 3 physicians who say, you know what, transparency is not a bad idea. I already carbon copy my patient on a copy of my progress note every time that I send back to the referring physician. I think the patient has a right to know what's going on. 4 of the physicians looked at us out of the side of their eye and said, this is not at all a good idea. One of whom actually said, the only reason I will agree to participate in your study is that because from your description, it looks like you're doing a rigorous academic analysis, and at the end of the year, you will know exactly how bad an idea this is. And by the way, how large is your legal fund for the lawsuits that it will inevitably result as out of your study? So we ran this for a year with 100 patients, and at the end of the year, 7 out of 7 physicians thought that wasn't a big deal. Some of them thought, I didn't even realize you were still running the study. I heard almost nothing from my patients about it. Having said that, though, even though we gave them the positive outcomes that, no dramatic increase in phone call volume, we ended up paying for 4 hours of a nurse's time in that clinic because of the anticipated deluge of incoming questions, and it ended up being about 5 minutes a week of effort, mostly focused on the first 3 months, where patients complained, how come the dictation isn't available yet? And we said, it takes us 2 weeks to get that dictation back. That's why you don't see it. We don't even see it. Or why is the TSH, the thyroid stimulating hormone, why does it take 2 days for me to get it? We don't even get it for 2 days. What are you talking about? So once you get those things out of the way, the phone calls disappear, and patients say, I love that you trust me with the information. Patients love it, right? So no question. Patients will come to us and say things like, I don't always read in my doctor's progress note, but the fact that you show it and make it available to me means that I can trust you. You're not hiding anything from me. And what's even more important is, can you imagine, and one of our patients said this, I flew out of town, I went out of town, lost my luggage, all my meds are gone. Do you know how hard it is to convince a urgent care doctor, really, I do take Vicodin. I really do. And instead being able to say, if you have a web browser, I can give you my chart. Could I have 3 days of my pills? It's a very different conversation. I have ownership. I get to, I participate in my own care. It's a very different feeling. So we took that data back, and this is the socio-political failure that is me, is that I took that data and I went back to the nurses, and the nurses thought, you know what? Patients call with much more interesting questions. They're better educated. They don't call and say, what's my echocardiogram result? They say, I see my EF, ejection fraction, went from 27 to 36. Is that the digoxin working? Because I was reading about that. So that's a very different question, right? And then the administration thinks, well, this is a loyalty tool. Patients like us and they'll stick with us. And you talk to the doctors and they say, so what's the Kansas City cardiomyopathy symptom score? It didn't go down, did it? You didn't improve care, did you? You didn't improve reduction in ER visit rates. You didn't reduce clinic rates. You didn't reduce hospitalizations. This study's a bust. Turn it off. Honestly, the 7 physicians, told us, unified voice, you should turn it off. And it wasn't until we got a spontaneous email campaign from our patient participants, you can't turn it off, I love this thing, that physician said, well, it's not much work, let's just leave it on. We underestimated the cultural shift required in physician attitudes, even within the clinic that we studied. So I naively waltzed over to the physician leadership committee meeting and said, hey, we have this thing where we published a randomized controlled trial with good data that patients love. We'd like to turn it on system-wide. And I was, at the end of the discussion, politely asked to leave and never come back. Because everyone will say, sure, everyone knows that cardiology patients are easy. My patients, complicated. Kind of crazy, and I know they're going to ask a lot of questions of me. It couldn't possibly work in my practice. And it took, embarrassingly, a decade and a half to get to the point where I'm actually proud to announce we're going to be an open notes organization as of May of this year. So, as was said earlier, sometimes you have to outlive your detractors and keep going. And who was it said? It's not failure until you decide to quit. And I think that there's a lot to be said for that. So,
thank you for that. I want to ask Sharon and a couple of you and feel free to please chime in. One big piece of this is, of course, data security. There's the trend that HIMSS published a study, I think in late 2014, suggesting that 83% of healthcare executives reported that they use some type of cloud-based service. These numbers should not surprise anybody in this room. And it's also projected that cloud services in healthcare will grow to a $9.5 billion market by 2020, projected. So as we think about this and we are moving our data, large reams of data to the cloud, and we've talked about this in some of the past panels, but I'd like to get your perspectives on this if possible, starting with you, Sharon. What cybersecurity questions or policies are you thinking about, and are you grappling with at Microsoft in this regard, around the sensitivity of this data, how it should be protected, and how cloud service providers should, what role they should play?
Right. So, there's been this huge spate of ransomware attacks recently, and so this issue is very, very topical. I have a number of thoughts on this. The first is that I think it's actually good. Somehow the way that question was set up, it was like, now we should all be really scared because our data's in the cloud. But in fact, if you think about a cloud vendor, which we are one, this is our job. Our job is to keep your data secure. It's not being. Many of these attacks come because the software is not updated. The room isn't really secure. A graduate student was let in. Whatever. I mean, there are all sorts of reasons why a professionally run data center can be much more secure. Nobody's going to use our cloud unless they trust us. That's the bottom line, and we know that. And so it's really a big deal to make sure it's secure. The second is we were actually the first cloud vendor to sign BAAs, and we don't charge anything extra for a BAA because basically, we know that the trust is really important. But I actually think that looking ahead, so that's the basics. But I think looking ahead, there's a lot of things that people can do. And fortunately, because I sit in a research organization, I get to see all these amazing developments going on. And some of these are some really interesting things in security. And there's one in particular that I want to talk about, which is it's called homomorphic encryption. It's a mouthful. But it's interesting to me, we're not the only ones working on it, we just happen to have made some really interesting progress lately. There's a code library in CodePlex, if any of you are open source aficionados, for this technology, and what it does is it allows to do real computations, like for example a machine learning prediction on data that stays in encrypted form. So the way this works, you have your data, say you have your genome. You would like to know something about it, but you actually don't want to share your genome with Microsoft. Okay, no problem. You use the encryption library, you encrypt the data on your computer, you send it up to the cloud, stays encrypted. We compute on it, we predict, in a particular demo we did it with a flower genome, so there was no PHI. Predict something about, like in this case, it was how soon will the flower bloom. The result is also encrypted, sent back to you, you decrypt it. Okay, so imagine it's actually something you care about, like, am I at risk for an autoimmune disease, okay? And this technology, the theoretical basis of it has been around for several years, but it used to be like, 15 minutes, 15 hours. Over the years, people brought it down to where it's now actually practical to do. The great thing about it is, we want you to trust us, but you don't actually even have to with this technology. And the reason I'm excited about it is because I actually see there's a big Gordian knot in data sharing. And I see this as a researcher, which is, we could do, this came up on the last panel, we could do so much if we could bring all the data, if we could aggregate all the data in the US, imagine how big the data would be and how many insights we could derive. But we can't because nobody wants to share that data. And why don't they want to? I thought it was very telling that the White House's Precision Medicine Initiative came out and, it was first announced at a State of the Union address. And several months later, what happened? Does anyone remember? Were any of you, besides me, in the OPM hack? Yeah, so that was my second hack. My first time my data was hacked was Microsoft's insurance company.
Oh, I was in the OPM hack. Yes.
You were too.
Both me and my husband were.
Yeah. So first, both of my hacks have to do with this. One was Primera Blue Cross is our health insurance company, so I was hacked there, and the second was the OPM hack, which happened not long after the Precision Medicine Initiative. And I had to say to myself, how are they going to convince 1 million Americans to give their genomes to the federal government after the OPM has just given away all of your social security number and your fingerprints and everything else to the world? And I will just tell you one funny story, which is that the only bad effect so far of that hack, they give you ID protection and insurance, whatever. They told me, somebody's applied for a credit card in your name and it's from Victoria's Secret. So I call the ID insurance company and I say, I didn't apply for a credit card at Victoria's Secret. What do I need to do? And the lady's like, are you sure you didn't apply for a credit card at Victoria's Secret? It wasn't until I got the card issuing bank sent me a letter saying, we're not doing this, let us know if you meant to do it. We're not going to issue this card. And then I got a human being I could talk to who wasn't accusing me of faking that I didn't really open a credit card at Victoria's Secret. But anyway, at least there's some humor to be had in all of that. But my point being, people don't want to share their data because they're afraid it'll get hacked, right? On the other hand, I at least would, I don't particularly want to share, I haven't had my genome sequence, but if I had, I wouldn't particularly want to share it for all the concerns people were talking about earlier. On the other hand, boy, would I sure love to know, from the aggregate data, what insights would apply to me and those I love, right? Mm-hmm. So it's a Gordian knot, we need to cut it. And I think that encryption could conceivably cut it. So now to the policy issue, right? So I forgot to mention, with homomorphic encryption, the other piece of it is, the cloud provider doesn't even have to have the key, right? They get the data, it's encrypted, they don't hold the key. They predict based on the encrypted data and send it back. They never decrypt the data, they never even see the key. So on behalf of the researchers, I tried to ascertain whether in that scenario, is this HIPAA protected data? Does HIPAA apply in that? Is it still considered PHI if it's basically total gibberish because it's been encrypted and you can't decrypt it, right? And I found the right law review article, and it said, it depends. We're not really sure. And so I think what happens is because this is, and reassured me, this is indeed a gray area in the law of whether encrypted data is subject to HIPAA or not, basically. HIPAA requires that you take adequate security measures, of which encryption can be one, but what it doesn't say is, if you don't hold the key to the encrypted data, are you bound by HIPAA? And I think that the problem with these gray areas is that basically what happens, especially in a large corporation, which will tend to be conservative and they're trying to do the right thing, they'll just say, oh, it's HIPAA, and that's not great either because, because there's, a smaller company, you'd like to have some innovation and flexibility, and I think if we could get more encryption out there, we could conceivably get more data sharing because it would help people like me to trust that my data, even if it's hacked, who cares? They can't read it.
Yeah. I mean, so we think encryption is critically important, and one of the things that we have standard encryption in our software, but we've designed it such that, say, Anschutz wants to use their encryption, it's very easy just to plug it in. So it doesn't have to be our encryption, it just, we obviously believe it needs to be encrypted, or it can be encrypted within encryption. You could use your encryption, and so, one, have it encrypted not only on devices, but also during transmission, and whitelists, right? So one of the things you can do is set up your software such that data can only be sent to certain URLs, to certain portals, to things of that nature. And so we always believe that security is a process, not a product, and it takes multiple layers of things to make that happen. And there are actually some fairly simple things that as software developers we can do to make it easy for the healthcare industry to feel comfortable with the data that's being provided, that it's not been modified in any way, that it can only be seen by or received by certain organizations or certain people. So I think that when you're looking at that, I don't know that you can have security without encryption when it comes to personal health information, but there are additional layers that can be added that make it even more secure and more trusted.
Right, and I'm sorry, I didn't mean to imply if it came across that technology is a complete solution to security. I didn't mean to imply that at all. I just think it can help, and obviously there's many other elements to it. If you look at most breaches, there's a human element in them somewhere.
Yeah.
So.
That's right.
So from a cloud perspective, in terms of data security, I would agree with my colleague that it's not necessary that cloud is any less secure, and sometimes it's actually more secure because that's their business. It's only 1/20th of our business here to be secure with the servers, and so having servers on premise here doesn't necessarily mean it's safer as opposed to having it hosted somewhere where professionally this is what they do. We're always vulnerable to the social hacks as well. Someone calling and saying, oh really, I lost my access and I'm trying to take care of a patient here, can you just go ahead and reactivate me, and they use a name, they drop a name, and you're in using a phishing attack. So these sorts of things are less likely when you're at a cloud and you set up your policies and procedures in the right way. I would argue, though, that it is true that HIPAA is outmoded because, HIPAA was, in the early days of social media, and now, what is it? TheOnion.com had this lovely article about Mark Zuckerberg, the director of the Facebook Transparency Initiative for the CIA. What a great article that was. How we are now systematically gathering tremendous amounts of data because people volunteer it because they get value from it. But that moves the discomfort level one further stage out. And who's heard of the Facebook research product that was? It's a phenomenal work where 600,000 Facebook users, and if you read your user agreement, you agree to be in a potential study where they randomly took half of those folks and gave them slightly more positive Facebook feeds, and then the other half slightly more negative Facebook feeds. So in the positive half you have more cat videos, you have more positive comments from your friends, and then on the negative half you see more down comments from your colleagues. And they saw a change in behavior where the folks on the negative side tended to post less or post more angry comments. And the folks on the positive side tend to post, feed back into the positive loop of positive pictures, fun videos, I'm enjoying my life kind of a thing. Now you're changing medical health with these sorts of interventions, this social contagion type of idea. And then that feeds into the next thing, which I was reading about in the New England Journal, where it turns out I think it's the Framingham data set, where it's not, your predictors of obesity aren't just with you and your doctor and how successful you are, but it's with not just the first layer of relationships, but their friends in the second layer, and their friends. And the likelihood that you're overweight has to do with 3 network relationships out from you. What the heck is that about? And how can we use that in a positive way in healthcare? And is that okay to do? And do we need to sign a HIPAA consent for that sort of thing? I mean, we're completely outstripping what HIPAA was originally designed to do. So I think, yes, we do need a conversation about privacy.
I agree. On that note, I think it's time to open it up to questions from the audience. Right here in front.
I have a chart in one hand, I have the EHR in the other hand. Is there any difference in the ownership?
I don't know.
You're talking paper medical record versus the electronic health record, and at this point it continues to be the organization, the healthcare provider that provides your care is the official one. Well, we are, as you can tell, we're trying our best to have the patient be engaged in it, but the patient doesn't have the final say. You know, we constantly have requests for amendment from our patients, and we consider them seriously. We have a patient family-centered council of 30 patients who sit and work with us every month about what the right policies are for us to manage this healthcare data. It belongs to, and by federal regulations, it belongs to the healthcare provider. But we, as much as possible, want our patients to help us decide how best to use it. But having said that, patients will say things like, you got this wrong, you need to fix it, and we will take that seriously. If it's a factual error, we'll fix it. However, we have patients saying, I want you to strike this from my record because I don't want my insurance company to know what I told you about my alcohol, and you decided that was affecting my heart failure. That may be true, but I don't want it in my record. Well, who's right? Who gets to say that? And does the patient get to trump the doctor and take that out of the record, and the next doctor doesn't have that information, and we make maybe not as good of a decision on the healthcare? We don't know. And so these are the types of things we struggle with every month when we have these amendment requests, and we sit down and we struggle through those types of things. But the ultimate owner is the organization.
Any lawyers in the room that disagree?
I mean, so under federal regulation, HIPAA, the HIPAA regulations allow for patients, an organization, a covered entity is required under the regulations to provide a list, if you will, as to how the information has been used. But in terms of who owns the data, who has access to the data, covered, it is very covered entity centric.
But didn't HIPAA recently change to make it easier for patients? Because I remember in the era, you would want your record for some reason. You'd have to go to some place in the basement, physically go to some place in the basement, fork over lots of money.
Yes.
No,
now
isn't it? No. I guess I would ask a question: has that helped? Is it easier to get your record than it used to be, even if the hospital technically owns it? No.
I mean, personal experience, no. So HIPAA, right? It's privacy and portability, and everybody just talks about privacy and not portability. If you were to speak to the folks over at iTriage, the digital group over at Aetna, they're big proponents of the data should be owned by the patient. They feel that this emancipation of the data is what's going to open up all of this innovation and technology and allow us to accomplish the things that we've been talking about today. But right now, there's great ways to get the data in. You can get it in through HealthKit, and Epic will suck it in. And then Epic also says they'll partition it off so it doesn't overwhelm the providers. So you can get it in, but it's still a nightmare. Yeah,
get it in, but you can never get it back out.
Yeah. You can present it in more effective ways, but there's no good, and there's also no good form to get it out. There's not a standardized PHR out there that everybody is using. So still challenges.
A lot of the discussion has been about, I want to get the information of the person. On the panel where Anish was talking about the app, he's thinking of the user data. But the doctor-to-doctor thing is huge, and I don't know if we've, here's a scenario that we face. We have a visiting researcher who is doing a study that involves 7 medical institutions, actually maybe more by now. And they're trying to test, wearables and genomic data and so forth on a particular disease. And they need to be able to combine their data. Well, they want to go both directions. They need to be able to get the wearable from the patient here at this medical center and get it into his EHR over there at the other medical center. it's practically impossible. It's just really, really challenging. So I don't know if it's a question of ownership or it's a question of the Roche Motel.
So I want to amend my comment from earlier. Please don't take away the lesson that CT-Lin is personally blocking you from getting your data, because I think data blocking is not a thing. So there is a national media storm about, oh, so-and-so's blocking their data because it's anti-competitive, blah, 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 and we want to have the advantage. I think it's not a thing. You talk to physicians and you want to share the data for the betterment of the patient. Data blocking is not a thing. Please take the information, give it to your next doctor, absolutely. And please bring me the information from the previous doctor so I can take care of you. So I think this is a manufactured issue. Yeah. Having said that, despite the HIPAA regulation that the healthcare organization owns the data, we fully want to participate in the information sharing that's enabled by patients and with apps and with the FHIR standard and so forth. So actually, after talking to Anish earlier today, we're totally signing up for the FHIR standard this year to try to develop apps to move forward with it. Because I think the innovation model from the smart people in this room, this is my favorite Google quote, which is, there are more smart people who don't work for you than who do work for you. And we want to fully take advantage of that. The fact that, we're out there innovating as fast as we can, but there's only so many of us, and we want to, in a protected way, give you your data to be able to do something useful and interesting with it. That's the model.
One more question I think we have time for in the back. I was supposed to give it to a student first. Sorry, Dean Weiser.
I'm a student, so that should help. Dr. Lin, I'm really interested in that study you mentioned with Facebook and the 600,000 participants. I believe that they didn't need to follow any IRB protocol when they conducted that study, because they were a corporation and it didn't really fall within the legal field. Would we need to worry about that sort of thing with private health information? And if that's something that people are lazily consenting to, do we need to worry about informing users more, and how we'd go about doing that?
Academic lab.
You want to say?
Yeah, Facebook's defense was that the study was done in collaboration with academics who had IRB approval.
But your question is, the larger question is, before we start doing studies on patient data, do we need to do a better job informing folks that we're experimenting with their data, doing something with their data? And that slides into the whole Henrietta Lacks conversation about, we took your information and look at all the interesting stuff we did with it. It's a good question. And I know that our EHR vendor, and we are very cognizant of this idea. We love the idea that we have 30 patients in a patient family-centered council who tell us our business and tell us that, of the things we're trying to innovate on, we run them by our council. And for example, this is our personal dirty laundry, but it is an illustrative point. We have test result rules on how we release test results. So at present, we release blood test results to the patient in real time. We release plain film radiology, x-rays, to the patient in real time. Anything that's a CAT scan, a PET scan, an MRI that could be malignancy or cancer diagnosing, we delay for 7 days so that the patient can hear from the doctor first. And similarly, we delay for the pathology results so that the patient can hear from the doctor first. This is a collaboration where we had patients involved in the conversation and physicians involved in the conversation. Recently, and this is not great for us to reveal, but I'll say it because I'm sure this happens nationwide, we had an ultrasound result which we released to the patient immediately that revealed on a fetal ultrasound fetal demise. Means that the baby's dead. And the radiology report was assembled, and the patient on their mobile phone, ding, what? Gets the news, right? And the physician doesn't know about it yet, because usual process is it's a few hours before it's delivered, and there's a phone conversation between the ultrasound tech and the physician, and the interpretation's made. And so the request, as this bubbled up to the OB leadership, was, can we delay the result for 3 days? And there's something to that, because you would like to hear it not from your Bing phone, but from your doctor. And so we considered it. It was a conversation between about a dozen OB physicians across the entire Front Range, 150 miles within UC Health. And it was a considered hour-long conversation, debate, back and forth. And we decided, well, maybe that's the right thing. Let me take it to the patient family-centered council. An hour conversation at the Patient Family Center Council later came up with the response that, you know, this is a critical result. Don't delay it for 3 days. Figure out how to fix your process so I get to hear about it right now. And that's what we're doing with it. So this is the type of thing where it's the patient's voice that allows us to try to make the right decisions every step of the way. And if it applies to research, if it applies to just the way we release test results, is it applying to the way we do population health in the future, we need to have patients at the table to solve these sorts of difficult conundrums. So, thank you.
I feel Dean Weiser behind me, closing us out.
So the best spirit of all of us, and I would call upon the highest calling of lawyers, is creative problem solving, and that is a great note. The sets of interesting problems for us to solve we've discussed today are both daunting and inspiring. We've had a tremendous group of speakers, and now apropos what I've heard CT as Joy's Law, which is the smartest people are not working in my company, applies as part of why a community is so special. This is a special committee ongoing. Please share your ideas for how you want to engage with myself, Anna Noscasi, who's back there, Silicon Flatirons, Don Element, you see Don later, CT, or any of the moderators who helped us today, Annie and Bruce, both proud Colorado alums. Let me give you all a round of applause for just a great set of conversations. Everyone's reception with the general Silicon Flatiron admonition, please take special effort to engage with the students, talking about what they're doing, and in the case of a few of them, seeking help in their job search. Thanks very much.
Thanks. Thank you. Guys.
They feel like they're getting something.